اوكي تمام. Can we start? Assalamu alaikum wa rahmatullah. Welcome back to the second day of our fifth annual Saudi German Hospital Riyadh branch fifth annual meeting. I am happy that you are all with us today. Yesterday we have 450 attendants, and I am so happy by this achievement. I am grateful to all medical people, medical personnel, and healthcare workers who gave us their trust and they attend our meeting. Today, as we arranged yesterday together, and I told you how we are arranging this meeting, we are making a session for each subspecialty. And today we will start with nephrology and hypertension. And we are happy that we have our Professor Dr. Lutfi Al-Qurbi, consultant in nephrology in King Faisal, a specialized hospital and research center. And we want to thank Dr. Lutfi for coming with us for the fifth year. Every year he's with us, and we are happy that he's trusting us and giving us part of his time. Thank you, Dr. Lutfi. Let's start your presentation.
Thank you very much, Ahmed, and I would like to thank the organizer of this symposium for inviting me to speak today. Do you hear my voice clear?
Yes.
Yeah. Okay.
Yes, your voice is clear, sir, and the picture also is okay.
Okay, thank you. So what we're going to discuss today is about the new era and the management of diabetic kidney disease. Now, so here in this slide is the prevalence of the diabetes, and as you will all aware that diabetes is a highly prevalent disease, and if you can see in this diagram, in the x-axis is the age groups, and in the y-axis is the diabetes prevalence, and in the blue bar is the male, and the green one is the female. And you can see that as we age, the prevalence of the diabetes is increasing, and especially above the age of 65, the prevalence of around 20%. Now, this is the major cardiovascular outcome in patients with type 2 diabetes. Why we are concerned about the diabetes? Because of the major cardiovascular outcome in this patient. So you can really see that in the this diagram or this graph is the death from any cause, comparing a patient with type 2 diabetes, which is here is the blue line, with the match control, which is in the red line. And you can really see that the death from any cause is higher in patient with type 2 diabetes comparing to the match control. If you go to graph B, which is death from cardiovascular disease, also you will notice that a patient with type 2 diabetes has a higher risk of death from cardiovascular disease than patient with a matched control. And in the third graph is the death from coronary heart disease. Again, patient with a diabetes or with type 2 diabetes has a higher risk of death from coronary heart disease. And if we go to the last paragraph is D, which is hospitalization for cardiovascular disease, comparing patient with diabetes and matched control. So there's no question that having a diabetes is a risk factor of cardiovascular outcome. So what are the complications of diabetes? We know that the microvascular complication that we just said, which is the major adverse cardiovascular event, cerebrovascular disease, peripheral artery disease, coronary artery disease, and we know the microvascular complication, which is retinopathy, nephropathy, and neuropathy. Now, 50% of the patient with type 2 diabetes, they are going to develop diabetic kidney disease. So what is the prevalence of chronic kidney disease? Now, chronic kidney disease is highly prevalent disease, and it's affecting around 14% of the population. This is from the United States data, around 14% of the population are suffering from chronic kidney disease. Now, how we look at the prognosis of chronic kidney disease, and you can really see that here is the diagram looking at a patient with chronic kidney disease. We stage it from stage 1 to stage 5, and with albuminuria from no albuminuria to severe increase in albuminuria. And you can see that the red color is the very high risk patient, the orange color is the high risk patient, and the yellow is moderately increased risk, and the green is the low risk patient. So any patient who has stage 5 or stage 4 chronic kidney disease, regardless of their albuminuria, they're at a high risk of major cardiovascular event. Now, even if you have a mild drop in your GFR, but you have a significant increase in proteinuria, this could be also putting the patient at a high risk of cardiovascular disease. So diabetes is a risk factor of cardiovascular disease. Chronic kidney disease, regardless of the cause, is another cause of or another risk factor of cardiovascular disease. The lower the GFR, the higher the risk factor for cardiovascular disease, the higher the proteinuria, the higher the risk factor for coronary artery disease. Now, what are the causes of chronic kidney disease? Diabetes is the predominant cause of chronic kidney disease, contribute to around 44% of the patient with chronic kidney disease are having diabetes as the cause of their chronic kidney disease. Hypertension contribute to around 30%, glomerular disease could be 7%, and other factors contribute to around 18.4%. So diabetes is the predominant cause of chronic kidney disease. And so if we really want to prevent or treat chronic kidney disease or decreasing the prevalence of chronic kidney disease, we have to tackle the management of diabetes. So this is the natural history of a patient with a diabetic kidney disease. In the x-axis is the diabetic duration, and in the y-axis is the level of diagnostic markers. And you can really see that the changes in the early diabetes start with hyperfiltration. And after that, we start to see microalbuminuria, which with time will increase and becomes macroalbuminuria. And later on, we will start to see drop in the GFR, and lately, a patient may develop end-stage kidney disease or kidney failure. Now, this is a famous study called UKBDS in patient with type 2 diabetes. And what we learned from this study that 40% of a patient with type 2 diabetes develop albuminuria, and 30% develop GFRs below 60, so develop chronic kidney disease by GFR. And 60% with CKD did not have preceding albuminuria. So not necessary to have a preceding albuminuria to call it a diabetic kidney disease. That's why the definition changed from a diabetic nephropathy to a diabetic kidney disease, because you may really see a patient with a diabetes with low GFR and no preceding microalbuminuria or macroalbuminuria. And this is exactly what it showed in this graph. This is the chronic kidney disease in type 2 diabetes. And you see different circles now. One is the blue, which is a patient with albuminuria, and one is the orange, which is a patient with a low GFR less than 60. And this is in a different place in the world. And you can really see, for example, here in the United States, 27% of the patient has albuminuria. 10% they have both albuminuria and low GFR, and we have a 9% they have a low GFR without albuminuria. If you look, for example, in Asia, we have a 45% of patient with albuminuria, 17% they have a combined low GFR and albuminuria, and 6% they have only low GFR without albuminuria. So in this diagram, it's showing that ranging from 4 to 10% of the patient will have a low GFR with no preceding microalbuminuria or albuminuria in every part of the world. Okay, so then causes of chronic kidney disease in people with and without diabetes. So we know that in the left side is the people with the diabetes, and in the right side, people without diabetes. There is no question that the most common cause of chronic kidney disease in patients with diabetes is diabetic kidney disease or diabetic nephropathy. However, there could be other reasons why a patient develops chronic kidney disease in a diabetes. May not be necessary that the cause of chronic kidney disease is due to the diabetes. For example, hypertension could be playing part in causing chronic kidney disease in patients with diabetes. Ischemic nephropathy is another cause of chronic kidney disease in patients with diabetes. And other kidney disease, like glomerulonephritis, could be one of the causes of chronic kidney disease in the patient with a diabetic. So it's not unusual to see a patient with a long-standing diabetes, but his kidney disease was not due to the diabetes, due to other causes like glomerular disease, hypertension, or ischemic nephropathy. And as I told you before, that only 50% of patients with type 2, they are going to develop diabetic kidney disease. So why we are concerned about diabetic kidney disease? Because it can lead to end-stage kidney disease. It can also lead to a cardiovascular disease, and both end-stage kidney disease and cardiovascular disease are risk factors, and both of them is going to increase the patient morbidity and mortality. Okay, so let's talk about the management. So since we said this is diabetes is high prevalent disease, chronic kidney disease is also high prevalent, and those two diseases are a risk factor of a major cardiovascular disease. So how can we manage a patient with a diabetic kidney disease? How can we slow the progression? How can we prevent the major adverse cardiovascular event in those patients? Now, we start usually with strict glycemic control. And we know from the two landmark studies, one called DCCT, and the other one is the UKBDS. So in the DCCT, which was done in patients with type 2 diabetes, showed that controlling the glycemic control or strict control of the blood sugar reduced the nephropathy, neuropathy, and retinopathy by 60%. And patients with type 2, which is the UKBDS study, strict glycemic control reduced the microvascular complication by 25%. So strict glycemic control is important, and it should be the first line in the management of a patient who have a diabetes, since this is going to decrease the chance of the microvascular complication in those patients. The second intervention would be a blood pressure control, and there are many studies looking at management of blood pressure, and decreasing the blood pressure is decreasing the micro and macrovascular complication of patients with diabetes. However, with controlling blood sugar, controlling blood pressure, we still see a large number of patients progress to end-stage kidney disease or die from cardiovascular disease. So it sounds that this is really not enough intervention to manage a patient with diabetic kidney disease. So from 2001 to 2020, so this is many studies were published looking at the renal and cardiovascular protection in diabetic kidney disease. So I would start with 2001. We have a two landmark study. One is called RENAL and the other one called IDNT. And those are studies that using renin-angiotensin receptor blockers to slow the progression of a patient with chronic kidney disease and to decrease the major adverse cardiovascular event. So before we go to these studies, this is how the nephron looks in a patient normal in the left side, A, and B in the patient with diabetes. This is the patient with a diabetes, and you can really see that here there is afferent vasodilatation and there is efferent vasoconstriction. So if there is a vasoconstriction and the efferent, it means that the intraglomerular pressure is going to increase, and this is going to increase the sodium and glucose filtration, and then this increase in the sodium and glucose in the descending lobe of Henle. Now, this is the renal study, which was published in 2001. And in this study, they used losartan as a drug or the angiotensin receptor blocker. They have around 1,500 patients with type 2 diabetes. And they have chronic kidney disease since their serum creatinine is around 170 microgram. And they have also albuminuria or proteinuria with 1.2 gram or 1,237 milligram per day. And they give those patients losartan. They compared losartan with placebo. And their primary outcome was doubling of the serum creatinine, end-stage kidney disease, or death. And this is showing in this graph that patient with losartan has a 16 risk reduction in the primary endpoint, which is doubling of serum creatinine, end-stage kidney disease, or death. So this study gave us a hope that using renin-angiotensin receptor blocker in a patient with type 2 diabetes is going to decrease the incidence and the prevalence of end-stage kidney disease. Now, the same or another study with the same mechanism, which is blocking the renin-angiotensin system by renin-angiotensin blocker. And in this study, they used irbesartan, and they have around 1,700 patients with hypertension, type 2 diabetes, with nephropathy. And they compared irbesartan with amlodipine and placebo. So they also looked at amlodipine in this study. And the primary composite endpoint was same as the previous study. They want to look at the doubling of the serum creatinine, end-stage kidney disease, or death in a patient with diabetic kidney disease. So what did they find in this study? They found exactly similar to the previous study that using ARB or angiotensin receptor blocker in a patient with type 2 diabetes decreased the prevalence or decreased the progression of chronic kidney disease to end-stage kidney disease. And this was better than other antihypertensive medication like amlodipine. And that's why from these studies, the use of RAS blockade with ARB in a patient with type 2 diabetes become the standard of care in 2001. So far in 2001, the management of diabetic kidney disease was with glycemic control, blood pressure control, and RAS blockade with ARB. But unfortunately, the risk continued to be there. So and we still have a high risk of cardiovascular event in those patients. So yes, we have a good medication to control blood pressure and to slow the progression, but the risk unfortunately is still high or unacceptable. And you can see that although losartan here decreased the risk, but the risk is still significantly high in those patients. So it means that we still need other studies. And from 2001 till 2020, there were many studies after renal, and people try to combine two of RAS blocker, angiotensin converting enzyme inhibitor and angiotensin receptor blockers. And all these, the three studies looked at combining ACE inhibitor with ARB. And all of these studies, unfortunately, the on-target, the altitude study, the nephron-D study, which was the latest published in 2013, was negative. It didn't really show any benefit of combining ACE inhibitor with ARB. In fact, there was a harm. There was more of hyperkalemia and more of an acute kidney injury. And most of these studies were terminated early because of the side effect of the combination. And after that, from 2013, the combination of ACE inhibitor or ARB in a patient with type 2 diabetes becomes a contraindicated. Now, this is the Beacon study, which they're trying to use here, anti-inflammatory drug or badaxolone. It was also terminated, this study, because of a severe adverse event in those patients. So we left with the only positive study in 2001, which is renal and IDNT, which is both using ARB, till 2019. And we have two major studies. One is called Credence and the other one called Sonar. And in 2020, we have a study called DABA-CKD and Fidelio diabetic kidney disease, which was recently published a few months ago. So let's start with, this is the timeline of the diabetes cardiovascular outcome trials. There were many trials done from 2013 to 2020 looking at the new diabetic drugs and the safety of these drugs as a cardiovascular outcome. And fortunately, most of these, they looked at them, or reanalysis of this study, they looked at a patient with a diabetic kidney disease. Now, those are landmark studies that approved the use of SGLT2 inhibitors in a patient with type 2 diabetes. This is called EMBARIG study, and the second one called CANVAS and DECLARE-TIMI. Now, reanalysis of those studies showed that that those study has a nephroprotective as well as a cardioprotective effect. So we learned from these landmark studies that it was used mainly to look at a cardiovascular disease and in a patient on SGLT2 inhibitors. They also showed that there was a benefit in a patient with a diabetic kidney disease when using these medications. So what is the mechanism? How SGLT2 inhibitors slow the progression of diabetic kidney disease? Now, this is the SGLT inhibitors, which inhibit, this is the nephron, this is the afferent arteriole, and this is the efferent, this is the glomerulus, and the SGLT2 inhibitors works here by blocking the SGLT2 receptors. So the glucose and the sodium will not be absorbed in the proximal tubule. It will be delivered to the distal tubule. Sodium will increase in the distal tubule to the macula densa, and this will cause afferent vasoconstriction and decrease the pressure going to the glomerulus, and then this is going to be renoprotective to the glomerulus from a high pressure. And that's why even with using these drugs, it behaves like an ACE inhibitor, because by decreasing the glomerular pressure, there is expected some drop in the GFR. Now, so this is how SGLT2 inhibitors mechanism of action. They cause glucosuria, and this will cause weight loss and also good for glycemic control. And they cause natriuresis, which will improve the blood pressure, tubuloglomerular feedback, amelioration of volume overload, and this will decrease intraglomerular pressure, and this will cause renal protection as well as cardiovascular protection. Now, these landmark studies that I just showed you, that they looked at the use of SGLT2 inhibitors in a patient with type 2 diabetes. A reanalysis of them showed that also this medication is renoprotective. However, in these large trials, there was no albuminuria or only little albuminuria and normal or slightly reduced GFR. So we cannot really extrapolate the result of this study to a patient with significant proteinuria or significant drop in the GFR. And that's why in 2019, the Credence trial was published in the New England Journal of Medicine. And this study used canagliflozin. This is a double-blind randomized controlled trial. They looked at around 4,400 patients with type 2 diabetes, and they have a low GFR, which is from 30 to 90 ml per minute, which with a mean of 56, and they do have proteinuria of around 900 milligram per day. And all of those patients were on RAS blockade. And they compared those patients with canagliflozin as SGLT2 inhibitor versus placebo. And the result of the study, as you can see in the right side, which is the primary composite outcome, which is defined as end-stage kidney disease, doubling of the serum creatinine, death from renal or cardiovascular disease. So using SGLT2 inhibitor in a patient with type 2 diabetes with low GFR and albuminuria decrease the primary composite endpoint by 30%. This was a promising study, and it showed us a good rule of using SGLT2 inhibitors in a patient with a diabetic kidney disease. Now, from 2019, SGLT2 inhibitors was added in the management of a diabetic kidney disease. So now we have glycemic control, blood pressure control, RAS blockade, and nowadays, since 2019, SGLT2 inhibitors was added to the management of a patient with a diabetic kidney disease. What about using GLP-1 agonists? This is a study looking at liraglutide and renal outcome in type 2 diabetes, and also looked at the composite renal outcome and showed that liraglutide decreased the composite renal outcome, which is end-stage or renal disease or decreasing in albuminuria by around 22%. However, the GLP-1 agonist trials, the major benefit from this study was seen driven by lower rate of microalbuminuria. So we're not sure if this is going to decrease the GFR as the SGLT2 inhibitors do, but definitely it reduced the micro or macro albuminuria. So glycemic control, blood pressure control, RAS blockade with ARB, SGLT2 inhibitors, and GLP-1 receptor agonist. Now, in the use of SGLT2 inhibitors in a patient with a diabetic kidney disease and the significant benefit make people think, so why don't we use this drug in a patient with no diabetes, in a patient with chronic kidney disease? And this is what DABA-CKD, that they use this drug in a patient with and without diabetes. So this is called DABA-CKD, which was published in last year, in 2020, in the New England Journal of Medicine. This is a multi-center randomized control trial, 4,000 patients, and they have a low GFR from 25 to 75. They're all having, not all of them diabetes, those patients with diabetes and without diabetes. Their proteinuria ranging from 200 milligram to 5,000, and they all have a high cardiovascular risk, all on RAS blockers, and they compare one of the SGLT2 inhibitors, here is called dapagliflozin, versus placebo. And the primary outcome of this study was sustained decline in the estimated GFR, at least 50%, end-stage kidney disease, death from renal or cardiovascular disease. The result is shown here, that using as SGLT2 inhibitors, the benefit was not necessary or was not only for a patient with diabetes, even extended to a patient with no diabetes. So the benefit of SGLT2 inhibitors can be also seen in a patient without diabetes. So this is the 30% risk reduction in the primary composite endpoint. Now, what is the safety and of using SGLT2 inhibitors? And this is from the two studies, at least Credence and DABA-CKD. And we know that there is a drop in the GFR once you use SGLT2 inhibitor by around 5 ml per minute. However, if you really look at the GFR after 3 or 4 years, you will find the GFR in a patient who's taking the SGLT2 inhibitors, here is canagliflozin, is better than the placebo. So we're expecting that initially when you use this drug, there will be a drop in the GFR, is like this, that we learned that from also using ACE inhibitor or ARB. However, the long-term benefit of this lower GFR is better than not to use this medication. So there's no difference in amputation or fractures in those patients. And why we're saying this? Because the previous study that showed that there is more amputation or fracture in a patient who's in SGLT2 inhibitors. Now, these studies show that there's no difference in amputation or fracture. There is no hypoglycemia in non-diabetic patients. Remember that the DABA-CKD is including patients with no diabetes, and these drugs does not cause hypoglycemia. So even if you use it in a patient without diabetes, there was no hypoglycemia and no diabetic ketoacidosis. So this is a latest study which was published 2 months ago, which is called EMPEROR trial. And this study showed that one of the SGLT2 inhibitor, here is empagliflozin, reduced cardiac death and hospitalization for heart failure. So this drug becomes very important, this group of drugs, the SGLT2 inhibitors, in a patient with heart failure. So this is a study, randomized control study. They looked at around 3,700 patients with heart failure, class 2, 3, 4, and they have ejection fraction is less than 40. and 50% are diabetes. Remember, so this drug can be used in non-diabetes, although it's an oral hypoglycemic agent, but it can be used in non-diabetic patients. So 50% only in this study have a diabetes, and 50% were not diabetic, but they're having a heart disease and heart failure and low ejection fraction. And they compared empagliflozin with placebo, and they looked at the composite of cardiovascular death or hospitalization for heart failure. And it showed that using empagliflozin reduced the cardiac death and hospitalization of heart failure by 25% comparing to placebo. The last study in the management of a diabetic kidney disease was published also recently in October 2020 by, it's called the Fidelio DKD trial, which they used finerenone, a non-steroidal selective mineralocorticoid receptor antagonist. And the question in this study, whether adding finerenone to RAS blockade in patients with chronic kidney disease and type 2 diabetes is renal or cardio protective. So this Fidelio diabetic kidney disease trial is a multi-center, double-blind, randomized controlled trial, 5,700 patients with type 2 diabetes and chronic kidney disease. So the population here is diabetes with chronic kidney disease, and they compared finerenone versus placebo. They do have proteinuria from 30 to 300, and they have a low GFR from 25 to 60 with retinopathy, and all patients are on RAS blockade. The primary endpoint was kidney failure, a sustained decrease of at least 40% in the estimated GFR from baseline, or death from renal cause. The secondary endpoint was death from cardiovascular cause, non-fatal myocardial infarction, non-fatal stroke, or hospitalization for heart failure. So what does this study show? So this study showed that there's a significant decrease in the primary composite endpoint in the group who used finerenone by around 18%. And the secondary composite endpoint was also significantly decreased by 24%. So using finerenone decreased the primary endpoint, which is kidney failure, sustained decrease in GFR, and also decrease the secondary endpoint, which is death from cardiovascular disease. And now in 2020, how can we manage a patient with a diabetic kidney disease? No question that we start with glycemic control, blood pressure control, which is obviously has to be below 130/80, and glycemic control, hemoglobin A1C below 7%. RAS blockade with ARB is a mandatory in all the patients unless there is a contraindication for it. SGLT2 inhibitors should be used in the management of a patient with a type 2 diabetes, provided that their GFR is above 25%. So this drug should only be used when the GFR is 25 or more. GLP-1 receptor agonist is another drug that decreases proteinuria. We're not sure whether it decreased the GFR, whether it improved the GFR or not. And lately, only one study which was recently published, which is using finerenone, and this could be a drug in the future in the management of diabetic nephropathy. Thank you very much for your attention, and I'm ready if you have any questions.
Assalamu alaikum. Thank you, Dr. Lotfi, for this presentation. We really need to hear about how to manage diabetic nephropathy, and especially the recent updates about SGLT2 and GLP-1 use. I have one question. When we start using SGLT2 inhibitors, do you notice that some patients have increased risk of urinary tract infections?
Now, thank you. Very good question. I think any drug that you will use, you would have to know what's the expected side effect, and we learn the side effect from the previous studies. Now, the risk of having urinary tract infections, and especially we're talking about maybe a fungal infection, is in these studies ranging between 1 to 2%. So it's a very low risk, and we shouldn't really worry about it. We should, of course, instruct the patient that there is a risk, but it's a very, very minimal. But the benefit is really exceeding the risk, and that's why the benefit of this drugs exceeding the risk. You can deal with the risk if it happens, which is in less than 2%, managing it whenever it occurs. But I think it is a very small percentage who develop this infections.
I agree with you, sir, that it is low risk, but sometimes we face some cases coming with infection already. Do we have to stop the SGLT2 or not?
No, as I told you, unless if the patient is not infection, you cannot really control it. Most of the infection is treatable, and the drug should really be continued. Now, there's a reason why those patients may have infection. You know that this drug causes glucosuria, and having a glucose that may increase the risk of having urinary tract infection. I have many patients now in my clinic is on SGLT inhibitors, and I have to say that I did not really see one with urinary tract infection yet, and hopefully I'm not going to see. But I don't really have I did not reach a large number to really comment on this. But I think this drug is now used, and I'm sure everybody will have his experience about the risk of infection.
No, so if you will have a patient with pyelonephritis, for example, will you stop SGLT2 till infection is resolved or not?
We don't know the answer to this question, but I think it is if you want to stop it for a few days, that's fine. Yes. But there's no guidelines that saying that you should really stop it, and I think you should treat the infections. However, if I have a patient that he has a recurrent infection and I could not really control, of course I will think about stopping it. But as I said, from the previous studies with a follow-up of 5 years, no one stopped the medication because of the side effect.
Okay, that's good. So you recommend that we can, based on the scientific background, we can stop it for a few days till resolution of infection, right?
The scientific, they did not say stop it. But I'm saying that, you know, I don't think the benefit is really it's going to be lost if you really stop it for a few days. So it is fine to stop it for a few days and then you can restart it.
Agree. Yes. It seems logic. Thank you, Dr. Lotfi. Another question, sometimes some patients, when you start SGLT2, they suffer from polyuria because there is natriuresis. We lose some sodium. So sometimes the patient was on ARBs or ACE inhibitors as part of management of chronic kidney disease. So sometimes I have to reduce the dose of the antihypertensive. Do you notice this also?
Yes, correct. And you should really expect a patient to have polyuria or increase in the urine output. In fact, the patients that are having, and even in the literature, especially if they're taking a diuretic, you would have to decrease the dose of a diuretic because they complain of this. And I have 2 patients that I have to stop the diuretic. They were taking furosemide. And when I started the SGLT inhibitor, they become more polyuric, so I have to stop the furosemide. Furosemide is not a renoprotective, so as far as the patient is polyuric, I think it's fine to manage without furosemide. Now, SGLT2 inhibitor decrease the blood pressure, and decrease and Lasix also decrease the blood pressure. So it's fine to stop the diuretic if the patient cannot tolerate the combination of Lasix and SGLT2 inhibitors.
Okay, one last question, sir. I am sorry to disturb you. Did you use in your patients SGLT2 inhibitors in non-diabetic chronic kidney disease?
No, I did not really use it. So it is not really approved for use in non-diabetic kidney disease yet, but I think this is really promising, and I'm sure it's going to come in the future, and it's going to be part of the drugs that should be used in the patient with.
So it is off-label till now, and no recent study on this.
True.
Okay. Shukran, Dr. Lotfi. We are very grateful to you, and sorry to disturb you all this time. And it was very valuable time, especially this discussion. Myself, I get used to learn from you, and thank you, Dr. Lotfi.
Thank you very much. Thank you.
Thank you. And now we will have the second presentation with our Dr. Yassine Muhammad Al-Hamad, consultant nephrologist and interventional nephrologist. We are happy to have Dr. Yassine because he's the first one to go through this new subspecialty. We believe that nephrologists should do the intervention. And Dr. Yassine is the one who makes this dream true and becomes the first one to achieve this board from King Faisal Specialized Hospital. And Dr. Yassine will talk to us today about early versus late dialysis initiation. It is very difficult situation where we find our patients to do dialysis or not to do dialysis. And I think most of the nephrologists prefer the safety and the start dialysis or promise or give the order of dialysis. But I think only those who are talented can delay dialysis. Let's start with Dr. Yassine, and I hope everyone will enjoy this presentation.
Assalamu alaikum. Thank you everybody for attending. I'd like first to thank the organizers and everybody attending today for your time. Today I'll be talking about two topics. First, the early versus late dialysis initiation in acute kidney injury. And the second will be about a brief idea about dialysis access and vascular access. So I'll start with the early versus late initiation. First of all, I would go through the definition of acute kidney injury, some basic information before we go to examine the evidence that we have. Acute kidney injury was defined in many ways by many different bodies, but the most recent and the most widely accepted definition and classification or staging is that of the Kidney Disease Improving Global Outcome Guidelines and Recommendations. So the definition of acute kidney injury is defined as increase in serum creatinine by 0.3 milligram per deciliter or 26 micromole per liter within 48 hours, or an increase in serum creatinine more than 1.5 times the baseline within 7 days, and or a decrease in urine output to less than 0.5 ml per kg per hour for 6 hours. So staging, again, we'll be using the KDIGO staging, though we have other staging classifications like Rifle criteria or acute kidney injury network staging as well. So the most, as we said, the most recent and widely used is that of KDIGO, and this divided the acute kidney injury into 3 stages. The first stage is an increase by 1.5 to 1.9 times from the baseline within 7 days, or an increase by 0.3 or 26 micromole per liter within 48 hours. The urine output criterion for the first stage is a urine output less than 0.5 ml per kg per hour for 6 to 12 hours. The staging is important because we will need it later in this lecture as we go through the evidence. Stage 2 is defined as an increase by 2 to 2.9 times from the baseline, or the urine output less than 0.5 ml per kg per hour for 12 hours or more. Stage 3, increase by 3 times from baseline, or an increase from normal to 353 micromole per liter, or the need for renal replacement therapy, or in a patient younger than 18 years of age or pediatrics, an estimated GFR or a decrease in estimated GFR to less than 35 ml per minute. The urine output criteria are a urine output less than 0.3 ml per kg per hour for more than 24 hours, or anuria for more than 12 hours. In general, the accepted indications for renal replacement therapy are refractory fluid overload, severe hyperkalemia refractory to medical management, signs of uremia like uremic pericarditis, uremic encephalopathy, or otherwise unexplained decreased level of consciousness, severe metabolic acidosis of a pH less than 7.1, and other indications of dialysis like alcohol intoxication or drug intoxications. When we think about initiating dialysis, there are many factors that we should consider, like the severity of acute kidney injury, the trajectory of increase in creatinine and urea, urine output, and how is it developing over the days, acid-base status, potential risks of renal replacement therapy. We need a line insertion. It comes with its own complications. The severity of a clinical illness and other factors like the availability of the machines and the staff, and we saw that very clearly in the most recent pandemic and the need for ICU beds and dialysis machines. So in the KDIGO guidelines, they made it clear here in the second point that the decision to start renal replacement therapy should not use a single test like blood urea nitrogen or creatinine or the like. So what is the theory behind early initiation of renal replacement therapy? Why do we want to start early? There are some theoretical advantages of starting early, like controlling uremic toxins and metabolites, improved fluid management, acid-base hemostasis. This all will improve the cardiac function, or controlling all these factors will improve the cardiac function. And theoretically, it was thought that this would improve the hard outcome, which is survival or mortality. The drawbacks, as like the logical drawbacks, are infections, as we have to have vascular access, bleeding from anticoagulation, etc. So there is one systematic review and meta-analysis examined 15 trials and presented the results of those 15 trials. Actually, after examining all these 15 trials, the 28-day mortality odds ratio was 0.45, which with significant confidence interval, which supports the use of early or favors early initiation of renal replacement therapy. Those trials were mostly prospective trials. 9 were prospective, 2 were randomized trials, and 4 were retrospective. So do we have controlled, randomized controlled trials that examined this topic? Actually, since 2016 till last year, we had only 3 major trials. The first trial we'll be talking about is the Akiki trial. It was published in New England Journal of Medicine in 2016. It is a multi-center trial that was conducted in France. So the hypothesis in this trial was that delayed initiation reduces absolute 60-day mortality by 15%. Total number of patients in this trial were 620. Their inclusion criteria were admission to ICU with acute kidney injury compatible with ATN, invasive mechanical ventilation, and at least one of the following criteria, which are consistent with KDIGO stage 3 AKI. So they were divided or randomized into 2 groups: early renal replacement therapy, where the renal replacement therapy was initiated less than 6 hours after criteria were met. The delayed group is initiated if one of the following criteria were met, which is oliguria or anuria for 72 hours, blood urea nitrogen level more than 40, serum potassium more than 6, acidosis with pH below 7.1, metabolic acidosis, and acute pulmonary edema, etc. So in the early strategy, 98% of the patients randomized to this arm commenced on dialysis at a median of 2 hours from randomization. In the delayed strategy, only 51% started dialysis at a median of 57 hours post randomization. If we look at the primary outcome, the delayed renal replacement therapy did not result in improved patient survival. Actually, the delayed and early strategies were equal, where there was no difference in dialysis dependence, but catheter infections and hypophosphatemia were observed more frequently in the early intervention group. Another randomized controlled trial, the ELAINE trial, was published in JAMA in 2016. It also examined the same thing, early versus late initiation. It was a single center trial done in Germany with a total number of patients of 250. The principal hypothesis that was that early RRT reduces 90-day all-cause mortality by 18%. So they included patients with KDIGO stage 2 AKI and included a plasma INGAL more than 150 as an inclusion criteria, plus one of the following: either severe sepsis, need for vasopressors, refractory fluid overload. So in the ELAINE trial, they randomized patients into 2 groups: early, within 8 hours after randomization, and delayed within 12 hours of stage 3. The early within 8 hours of stage 2 AKI criteria, and delayed within 12 hours of stage 3 or development of an absolute indication of renal replacement therapy. So in the early group, there were 112 patients. Almost all patients started on renal replacement therapy at a median of 6 hours from time of eligibility. The delayed strategy, 92% of those patients started at a median of 25 hours. Now, among the critically ill patients with AKI, early renal replacement therapy compared to delayed initiation reduces mortality over the first 90 days. There are some significant limitations of this trial, that it is a single center, unlike the Akiki trial or the coming trials that we will see, and all those patients were surgical patients. Another thing was that the only modality that's used is CVV HDF, while in others they used HD, HDF, and SLIT, other modalities. Another 2 years later, another trial was published in New England Journal of Medicine, which is ICU Ideal. It was published in 2008. It's a French trial with multi-center, done in multi-center. The principal hypothesis was that early renal replacement therapy reduces 90-day all-cause mortality by 10%. They enrolled 488 patients, those patients who underwent randomization, and they used KDIGO stage 3 as an inclusion criteria. For early initiation, within defined or the early initiation group, the patients were started within 12 hours of meeting AKI criteria, and the delayed initiation, they were planned to start 48 to 60 hours following enrollment or development of emergency indication. So in the early strategy, 97% of the patients commenced renal replacement therapy, and delayed strategy, only 62% of those patients randomized to this arm were started on renal replacement therapy. Among those, 29% did not receive renal replacement therapy due to spontaneous recovery, and 8% died before initiation of renal replacement therapy. In the analysis, there was no significant difference in mortality between the early or late strategy, and delayed initiation of a patient with septic shock and severe AKI, but no immediate life-threatening complication. So there was no difference. So in the last year, in July, actually 2020, the START AKI trial was published, and it was by far the biggest trial. It is a multinational randomized open label controlled trial done in 15 countries and involved 168 hospitals. Their inclusion criteria were all adults admitted to ICU with kidney dysfunction, defined as serum creatinine of 100 micromole per liter in women and 130 in men. Severe acute kidney injury that was categorized as stage 2 or 3, depending on KDIGO classification. This is the same classification that we saw earlier. So the exclusion criteria were emergency indication, previous renal replacement therapy, advanced chronic kidney disease, uncommon causes like urinary obstruction or RPGN, etc. Presence of all the inclusion criteria and none of the exclusion criteria established provisional eligibility. One important thing they did in this trial, that they excluded all patients in whom the treating physician decided that this patient may need renal replacement therapy. So the clinical decision was given priority. The patients were randomized in 1-to-1 ratio, and discontinuation of renal replacement therapy occurred either due to recovery, withdrawal of life-sustaining support, or death. So in the accelerated RRT group, the renal replacement therapy was started within 12 hours, and the delayed group, it was started when an indication is developed, like pH of 7.2 or less, serum bicarb of 12 or less, evidence of severe respiratory failure, volume overload, etc. A total of 3,019 patients were recruited between 2015 and 2019. In the accelerated strategy, the total number of patients were 1,418, and in the standard strategy, in the accelerated strategy, it was 1,512, and the standard was 1,507. Those in the accelerated strategy who started dialysis were 96%, and only 61 in the standard arm. The primary outcome was death from any cause at 90 days after randomization, and they had many secondary outcomes. One of the important outcomes was dependence on renal replacement therapy and sustained reduction in GFR, and among others. So if we examine the baseline characteristics of both groups, we find it very similar in terms of the demographics like age, gender, weight, etc. And the comorbidities also, they were similar in that area. It included both surgical and medical patients. So we come to the results. The death at 90 days occurred in 43% in each group. So there was basically no difference between early or late, with a relative risk of 1. If we look at the secondary outcomes, renal replacement therapy dependence among survivors at 90 days, it was more in the early strategy rather than the late. A marginal increase, actually marginal increase in median length of stay in ICU was noticed in the late strategy. However, it was not really, it was statistically significant, but the numbers were very low. When we come to the adverse events, it was by far more in the accelerated strategy, like hypotension and the total adverse events and adverse events associated with renal replacement therapy, like hypotension or hypophosphatemia. They were more in the accelerated strategy. So to summarize the results, we had no difference in mortality, 90 days mortality. We had no difference in or a higher dependence on dialysis in the early group and higher side effects or adverse effects in the early group. As we said, it is by far the most or the largest trial when it comes to the sample size, almost 3,000 patients, while in the other trials it was between 250, 400 patients. The recruitment of patients from wide spectrum of ICUs and different backgrounds and diseases in different countries aid in the generalizability of the results. The limitation of this trial, they reported that they allowed clinicians to use their judgment in confirming full eligibility. So if a clinician decided that this patient needs dialysis, even if he does not meet the criteria, he will be taken out of this trial and he will be started on dialysis. So another limitation is that the adverse effects were more in the early strategy and partly attributed to pre-specified focus on reporting events related to renal replacement therapy. So that's, in summary, to summarize the whole topic, we have many trials done in this examining early versus late and acute kidney injury in ICU. And some trials support the early initiation and some are against this. However, as we have more and more evidence, we see that the early initiation may result in increased cost in the healthcare system, increase adverse effects on patients, and may not give the hard outcome of improved survival. So this is about it for the for my first topic. Dr. Ahmed, should I go to the next topic directly, or we take questions?
Questions?
Yeah.
Yes. What about start trial? Okay. You can just read.
This already answered. This is the whole.
Maybe this is an early question.
Yeah,
maybe
this is the early question.
Yeah.
So no need to.
Okay.
Good day. It's not clear. This question.
It's okay.
Yeah.
When you just
So the questions are not clear actually, and examining the effectivity of survival of COVID patient is beyond the scope of this talk.
Mm-hmm.
So if there is any other question.
No, I think till now we covered all the questions and the COVID topic is well covered. I just want to discuss with you what you do in your clinic. For example, I have some patients with serum creatinine, for example, 8 or 9, potassium is okay, urine output is okay, nutrition is even okay. Do you accept? And if you estimate the GFR, it is below 5. And if you collect urine and make it creatinine clearance, it is below 10. So do you go for dialysis or you just go for conservative?
So yes, so this lecture was about dialysis in the acute setting, but in the chronic setting, what I do is that I wait. I do not start dialysis until I prepare the patient, of course. Our patient should be prepared for either PD or hemodialysis when we reach stage 4, late stage 4 or early stage 5.
Or we start educating the patient and prepare him emotionally, even
mentally, emotionally, and then physically by creating an access. As you know, fistula is the second topic is about vascular access, so we'll talk more about it. He should be ready for initiation of dialysis once the patient develops symptoms at any stage, either weight loss or uremic symptoms in general. Then at that time we start, but we try to delay because the ideal trial, as we all know, that there is no difference between initiating early or late. For the chronic patients.
And for choosing the modality, do you usually choose continuous methods or hybrid method like SLED or the intermittent?
Actually, the intermittent methods, it depends on the case of each individual case, but the most commonly used is the intermittent hemodialysis, we know. It's advised that we start in gradual manner, like start two dialysis sessions per week, then increase if needed. But of course, we have to educate the patients regarding both famous modalities, BD and hemo.
This is for the chronic, okay? For for the acute cases, in setting of ICU, for example, usually you do CRRT continuous methods more or intermittent?
We do the continuous.
Continuous. Because I think for the last 2 years, we didn't see a study that make us have the decision of continuous modes with clear benefits.
Yes.
Till now,
I
right?
agree. I agree. Yes.
Okay. Thank you, Dr. Yassin. It was very useful discussion, and I am very happy to hear these answers. We will come back to the questions once again. Please, doctors who raised the questions, kindly clarify more. You have free space to raise your question and share your information with us. And now we will start the second presentation with Dr. Yassin about vascular access in hemodialysis. As I told you before, Dr. Yassin is interventional nephrology, and he's interventionist. And let's see what he can tell us about all this, about vascular access in hemodialysis. This one, right?
Yes.
Yes.
Okay. Thank you again, Dr. Ahmed. This talk will be about vascular access, and it's intended for general practitioners, internists, to give a basic idea about dialysis and what we use for dialysis. We'll talk briefly about the history, the types of dialysis access, and the complication of each, or the most common complication of each dialysis access. So regarding the history of dialysis, we know that the first successful hemodialysis was performed by Dr. Haas in Germany in 1924. And to access the bloodstream, he used glass cannula in the radial artery and another one to return the blood in the forearm to the cephalic vein. Dr. Clough was the first one to use rotating drum dialyzer in 1943. Actually, the first dialysis in 1924 lasted only for 15 minutes. And patients had very poor outcome until we'll see later in 1960s. So the cannula was to the femoral artery to obtain a very high pressure for the dialyzer, and both they used a mechanical pump to pump the blood like what we use these days. And the first AV shunt was created by Dr. Scribner in 1960. He used a Teflon material to the radial artery and connected it to the cephalic vein. It was an external shunt. And with the introduction of this shunt, he introduced the concept of maintenance or chronic hemodialysis. So just to give an idea, this is the rotating drum kidney or dialyzer, where they used to wrap a small tubes of cellulose tube that they used to cover sausage. It was used as blood conduit to take the blood in this rotating drum. It will be submerged in the dialysate to make this exchange of waste and electrolytes through it. This, as you can see, this is Dr. Scribner, and this is the Scribner shunt. It's used in Teflon material as we use. James Semino in 1966 created the first autologous AV fistula using patient's own vessels, artery, radial artery, and cephalic vein by side-to-side anastomosis. It provided adequate blood flow and was suitable for recurrent use. In 1972, 3 types of arteriovenous grafts were tested, actually bovine carotid artery, EBTFE, which is a synthetic material. This stands for extended polytetrafluoroethylene, and Dacron. The one that continued for use is the EBTFE material, the material that we are using those days to create AV grafts. We go now to the types of hemodialysis access. There are mainly 3 types: AV fistula, arteriovenous grafts, either synthetic or biological, or tunneled dialysis catheters. The AV fistula is also called autologous arteriovenous fistula. It's classified according to the anatomic location, either in the forearm, connecting the radial artery to the cephalic vein. It's called radiocephalic fistula. Or in the upper arm, utilizing the brachial artery with either the cephalic vein or the basilic vein. In general, an AV fistula requires between 6 and 8 weeks, may need more than that time for maturation. And we define maturation by the rule of 6, as we know. The diameter of the vessel will become at least 6 millimeter, the depth from skin to the vessel 6 millimeter, and the blood flow should reach 600 ml per minute. And we know by evidence that mature AV fistula is superior to graft or catheter, and relative risk of death is 32% higher than with catheter and 15% higher with graft. So the best option for any patient to start dialysis is to start it with a fistula. Also, it is superior in terms of frequency of infection. The worst is catheter, then comes the graft, then fistula. We'll talk about the infections in the fistula. It is very rare to have fistula infection. However, the way the fistula is being used or the cannulation technique plays a major role in fistula infection. This study or randomized trial compared buttonhole and raw bladder needling. We'll show pictures to explain what is buttonhole and what is raw bladder techniques in the next slide. However, the most important thing to know is that the buttonhole technique carries double the risk of infection when compared to the raw bladder, which is the preferred and even the newest Kudoki vascular access guidelines. So on the left, you can see the raw bladder, where the full length of the fistula is utilized in rotating manner. So the needle during one dialysis session is placed in one area, and the next it has to be shifted to another one for both the arterial and the venous. This way, we will limit the chance of infection and other complications like development of aneurysm or rupture. On the right side, you can see a buttonhole, a fistula with a cannulated in a buttonhole technique. The whole idea of the buttonhole is to have a track created first in the first 5 or 7 sessions via a sharp needle. Then subsequently, this fistula is will be cannulated using a blunt needle. This is only used in special circumstances, and it's actually we are discouraging our nurses not to use it unless absolutely necessary. One of the indications is having a deep fistula or difficult or short cannulation segment. Aneurysms, one of the most common complications of AV fistula. A true aneurysm occurs in varying frequency between 6 and 51, according to different reports. It's defined by the Society of Vascular Surgery as circumscribed dilatation of an AV fistula involving the 3 layers of the vessel. It's different from pseudoaneurysm, in which it involves the 3 layers, while pseudoaneurysm represents only 1 layer and represents a fibrotic sac, and it is basically a defect in the wall of the vessel. So a classification was made for the aneurysm into 4 types. Type 1A, where the whole vein is dilated and aneurysmal. The type 1B, where the proximal part only is dilated around 5 centimeters from the anastomosis. Type 2A, where at least one localized dilatation of a vein. Usually this localized dilatation occurs as a result of repeated cannulation in the site at the same site, like they call it regional cannulation. In type 2B, there is both post-anastomotic. It's a combination actually of type 1B and type 2A. Both post-anastomotic within 5 centimeters plus one or at least one site of a localized dilatation. In type 3 represents an AV fistula that has no typical aneurysmal and has no special typical features. Type 4, it's basically a pseudoaneurysm and is detected or diagnosed by duplex ultrasound. Before talking about management, I'll just mention briefly that one of the major causes of AV fistula aneurysm is development of central vein stenosis or fistula stenosis. The other main cause is having a high flow fistula or big anastomosis. How do we manage aneurysmal fistula? Now, if the skin is intact, no depigmentation, no thinning of the skin, the treatment is only observation. No need for special treatment. If the patient develops depigmentation at the site of the fistula and the skin becomes very thin that it cannot be pinched between the index and thumb, then close observation plus elective repair should be considered. When do we consider emergent repair? If we see skin ulceration or spontaneous bleeding, this is an indication of emergent admission and repair. Now we move to the second option for vascular access, which is AV graft. Mainly, it is a synthetic material, like what we said, EBTFE is the most common material used. Other materials like bovine vessels and new humanized or decellularized human vessels are being investigated. Most frequently classified according to the configuration or location in the body. I'll show a figure to demonstrate later, either forearm, upper arm, or thigh loop grafts. The HERO graft or HERO device is a relatively new device that is used for special indication when a patient has a central vein stenosis. In general, conventional grafts need at least 2 weeks for maturation. It's actually the time that is needed for the foreign material to incorporate into the skin and form fibrosis around it. A new type of grafts that's called early stick graft with the ability to auto-seal after removal of the needle that can be used within 48 hours after placement. It is the early stick grafts are very good option for patients who do not wish to have central venous catheters. So this picture is showing the different configuration of the graft. Forearm, upper arm straight, upper arm loop, or thigh loop graft. This is what a HERO graft looks like. It's part graft. The part on the upper arm, as we can see here, from the brachial artery till the shoulder, is connected to a titanium connector, which then is connected to the other part, which is a catheter material that goes and ends in the right atrium. So the blood is continuously flowing from the artery to the right atrium. Graft infection is one of the most common complications. It's mostly introduced during cannulation. Graft excision, either total or partial, is almost always needed, and it will lead to prolonged catheter use after removal. Patients may present with fever, localized tenderness, and erythema with purulent discharge. Also, the classification of the graft infections, either superficial, deep infection will involve the subcutaneous tissue and reach to the graft material itself or the tunnel. Deep infection can be either localized or extensive. Extensive usually take place before incorporation of the graft or in an acute setting after placement. The last type of infection is intraluminal, where it is discovered after introducing of dialysis needle. Sometimes pus will come out indicating intraluminal infection. The last vascular access that we will talk about is dialysis catheters. Now, we use usually non-tunneled catheters for short-term dialysis and tunneled catheters for long-term dialysis. If we look at the non-tunneled catheters, the most common complication is infection. I found this article about the risk of infection between the subclavian, femoral, and internal jugular, comparing both of the three sites, examining which one has highest level of infection. When they compared femoral to subclavian, they found actually no difference in rate of infection between the femoral and the subclavian. And on initial analysis, they found that the internal jugular vein carries a lower risk of infection when compared to femoral, but after removing two of the studies in this meta-analysis, Dorenti and Nagashima, which considered as outliers, they found that there is actually no difference between the two. Unfortunately, almost 80% of the patients starting dialysis, they start through catheters for several reasons, either the system, the patients, the physicians, a lot of reasons. So tunnel dialysis catheter carry the highest risk of infection, central vein stenosis, and mortality. So there are two parts of the central venous catheter, the intravascular part and the tunneled part, the subcutaneous part. What makes it different from the temporary catheter or non-tunneled is the presence of dacron cuff that again incorporate into with the subcutaneous tissue, forming a fibrosis around it and creating a mechanical barrier to infection. So this systematic review examined the difference between the three vascular accesses in terms of fatal infection, all-cause mortality, and major cardiovascular events. And in the three variables, we found that catheters are unfortunately the worst. All-cause mortality also more with catheters, grafts more than fistula. So by this simple analysis, we find that fistulae are the best option for our patients. Infection of dialysis catheter may present as fever, may present with no symptoms whatsoever, or may present with fever, chills, exit site infection. Fever is most with dialysis. Other symptoms like hemodynamic instability, altered mental status, especially with dialysis as the endotoxins move with the blood movement. Exit site infection, as we see in the left side, the most is seen as redness on the exit site, and we may see tunnel infection or collection inside the tunnel. So in the Kidoki 2019 definition of dialysis catheter infection, clinical manifestation of one positive blood culture from peripheral source plus one culture from the catheter segment, either the hub or the tip, and they should grow the same organism. The management, this is a nice review about the management of catheter-related bloodstream infection. With this algorithm is a simple and useful way to deal with the catheter infection. It has two parts dealing with catheter infection: antibiotic management and catheter management. If uncomplicated, that's defined as quick response to empiric therapy, hemodynamically stable patient with no evidence of metastatic infection, 2 to 3 weeks of systemic antibiotics with catheter lock, or 4 weeks with catheter lock if the organism is MRSA. If hemodynamic instability or complicated catheter-related bloodstream infection, we need 6 to 8 weeks of tailored systemic antibiotic. When to remove the catheter? We remove the catheter when there is severe sepsis, hemodynamic instability, and we do not wait for the culture results. Some organisms are resistant to treatment, like Staph aureus, fungal infection, Pseudomonas. We remove the catheter in those patients. So the empiric antibiotic, usually we start with, it's different from one center to another, but usually we start with broad coverage of gram-positive and gram-negative, vancomycin and ceftazidime, and we adjust the antibiotic according to blood culture. When we talk about metastatic infection, we have some common infections like endocarditis, which is seen in 25 to 35% when the organism is Staph aureus. So it's recommended that any staph infection, we should obtain an echo to rule out infective endocarditis, and it requires at least 6 weeks of antibiotics. Other metastatic infections like vertebral osteomyelitis, discitis, spinal epidural abscess, septic arthritis are seen with catheter infection. The second and the very nasty complication of dialysis catheter is central venous stenosis. You see on the right side, this is a venogram showing almost complete occlusion with collaterals flowing in to the neck. This is due to catheter use. So in general, the causes of catheter of central vein stenosis, either the use of catheter, either related to intravascular device, either it's catheter, cardiac device like pacemakers, defibrillators, or peripherally inserted central catheters, or something not related to intravascular device like idiopathic fibrosing mediastinitis, retroperitoneal fibrosis, etc. The location of central venous catheter plays a major role in development of stenosis, and they've found that subclavian is the worst among all other locations, carries a 42% of stenosis. When we compare the right and left internal jugular, we find that the right internal jugular has a straight course from the IJ to the brachiocephalic to the right atrium. Sure. Yeah, sure. So we will pause the lecture now until the Adhan is finished. We'll start again, resume our lecture after the Adhan, and we'll try to finish quickly. So we were comparing the right and left tunneled dialysis catheter. We were saying that the right tunneled catheter has a straight course, while the left has three curves that make it more in contact with the central veins and predisposed more to stenosis. So according to Kudoki 2019 guidelines, the internal jugular the right internal jugular is should be the first choice, and the right is preferred over the left. External jugular can be utilized as well for a tunnel dialysis catheter. Femoral comes the third. Subclavian is the fourth site, and the last is lumbar. So we'll go now to the last area that we will talk about before we conclude our talk. It's about developing heart failure in patients with dialysis and AV fistula. This study was done comparing patients who before and after creation of AV fistula, and it showed that after the creation, the systolic and diastolic blood pressure were significantly lower, and development of atrial fibrillation was more with after creation. Again, there is significant RV dilatation and RV dysfunction, mainly because the blood is shifted to the venous side and goes more to the right heart. So the risk factors for developing heart failure in after AV access is baseline heart failure or heart disease, location of vascular access, proximal more than distal, mainly because of the higher flow with the proximal vessels due to higher caliber. Male 6, upper arm AV fistula, if done in the same arm that has a previously functioning AV fistula. That means after creation of a distal arm fistula, the arteries will mature as well by increasing in diameter and increasing in blood flow. If we lose the distal fistula and we decide to create an upper arm fistula, for example, utilizing the brachial artery, we will be having a bigger artery than usual, than the natural one, and higher flow. So this carries a higher risk of heart failure. High access flow is another measure of that we follow during dialysis for special patients. But what is or how high is high access flow? Actually, there is no clear or definite definition of high access flow, but the agreement that there is an access flow more than 2 liters per minute and access flow to cardiac output ratio more than 0.3 or 30% is a risk factor for heart failure. Diagnosis, they present as any heart failure with shortness of breath, especially with exertion, orthopnea, PND, tachycardia, JV distension. On examination, there is a special maneuver for patients with AV fistula, which is called Nicoladoni-Branham sign. After occluding the access with a sphygmomanometer for 30 seconds, we will notice that the heart rate will decrease, the blood pressure will rise. This is predictive that the fistula or the heart failure is due to high flow fistula. The options for treatment is first to rule out any other predisposing factor like volume management and anemia. The surgical interventions, it's not only ligation. Other options are there like fistula banding using a graft material or endovascular banding using sutures, interpositioning graft to limit flow, or Rodi procedure, which stands for reanastomosis using distal inflow. Distal inflow means smaller caliber artery. If all these measures have failed, then surgical ligation may be the final option. So in this article, they've suggested criteria to either go for fistula or to dialyze patients using catheters. All patients going for fistula surgery need to be evaluated from cardiac point of view using the New York Heart Association classification, ACC and AHA staging, and echo or ejection fraction. So it's suggested that if New York Heart Association class 1, 2, 3, we use distal arm AV fistula. And if left ventricular ejection fraction is less than 30%, we better, or the patient may better have an option of tunnel dialysis catheter. I think I've reached to the last slide in my lecture. If there is any question, I'm happy to take any questions, Dr. Ahmed.
Yes.
Let's try to understand it. The question is, when did you recommend PermCath from the start? I'm not sure if this question was related to the heart failure, but if you're asking about the last point, heart failure, then we have the slide there showing what is the PermCath if ejection fraction is less than 30. But if you are talking about comparing to temporary catheter, as I was discussing just now with Dr. Ahmed, that the recommendations, general recommendations that if a patient needs more than 3 sessions or expected to need more than 3 sessions of dialysis, he better have a perm cath placed. So in dialysis catheter-related thrombosis, did you recommend immediate removal or after anticoagulant bridge? Again, the question is not.
No, I will tell you. If you have dialysis catheter thrombosed, do you like to exchange it or to give thrombolytic? It doesn't mean anticoagulant. It means thrombolytic. Sometimes in difficult patients, we proceed to thrombolytic, but I don't know what is the scientific background.
Yes. Thrombolysis using TBA or any other form is an option to restore blood flow through the dialysis access or the catheter. However, if the catheter still did not, or the flow did not improve after subsequent sessions, the catheter exchange is recommended. So for how long anticoagulants and dialysis access thrombosis? I think you are talking about a specific case. Maybe we are facing this some difficult access that we use the catheters or use anticoagulation in order to avoid exchanging the catheter because we have multi-access failure. But the catheter exchange is the first option, I would say.
Is this fistula affected cardiac output and ejection fraction?
Yes, cardiac output will increase because the fistula is shunting. The creation of fistula will shunt blood from the higher pressure arterial to lower pressure venous. So the cardiac output will increase. And as we said that after ligation of the fistula, the effect will have a decrease an increase in peripheral vascular resistance and a decrease in cardiac output.
Okay, I have one question. We discussed already the insertion of permicast in acute setting and also the difference between the axes. But I noticed in your presentation here, according to KDOGI 2019, will be referred internal jugular. I agree. Then external jugular.
Yes.
It's difficult.
Yes.
It is very difficult.
Yeah.
Yani I insert many, alhamdulillah. Yani, but for external jugular, if we revise the anatomy, it is here subcutaneous, easy access. Even the trocar is so big to cannulate. We can cannulate with smaller trocars. But here the problem is here when you go subcutaneously in front of the clavicle to go to subclavian, because this is anatomy. Am I right? Yes. It is difficult to pass the wire in front of the clavicle, then to push the dilator, then push the catheter. So I feel it is quite difficult, right?
Yeah. I actually yes, I've done it before. I've done the external jugular.
Yeah, for me, I did it only once.
Yeah,
only once.
No. So the external jugular is more superficial and goes behind the clavicle and joins the subclavian vein. So it's especially in patients with limited access, in patients with previous catheter in the same place, you will find external jugular more engorged and bigger than the usual.
But it was behind the clavicle.
It was behind the clavicle, yes, and joins the subclavian. So if you, there are many ways of inserting a dialysis catheter. One by using the peel-away sheath and the rigid dilator. If you are afraid of injuring something, there is another way of having a stiff wire and then tunneling the catheter and feeding the catheter over the wire without the peel-away sheath. So there are options to overcome
I feel this external jugular is some troubles around it. So,
but it works perfectly just like internal jugular.
In some situations, yes.
Exactly,
okay.
Exactly.
Thank you. Thank you, Dr.
very much. Thank you for having me.
Thank you. So thanks for Dr. Yassin for having these two excellent presentations. And now we will go to another presentation. Here I am alone. So, Assalamu alaikum wa rahmatullahi wa barakatuh. Here I am again with you. I am Dr. Ahmed Al-Ghitani. I am a nephrology consultant. I am here in Saudi German Hospital. Today I will talk, this is my presentation about hyperkalemia. Most of us working in emergency, ICU, nephrology, or internal medicine, we know about acute hyperkalemia and how to manage it. But today I want to talk about chronic hyperkalemia. Let's see, I will start this presentation from the physiology of potassium and how our body is dealing with excess potassium. So, potassium is a major intracellular cation. Mostly it is intracellular, not extracellular. 96 to 98% of the total ball being located in the cells at a concentration of 140 to 150 millimole per liter, and only 2% are present in the extracellular, where it ranges from 3.5 to 5 millimole per liter. So if I will talk about hyperkalemia, so it means that the potassium is high in the serum. I am talking only about 2% of the total potassium inside my body. Fine regulation between the intracellular and the extracellular gradient is crucial for life. Can you imagine we are scared of potassium before, over 5.5? If only 1% or 2% of those potassium present in intracellular, it makes a big problem. Okay, and I will see with you right now. So, as it is the main determinant of membrane voltage, in fact, acute changes in potassium plasma level may have fatal consequences. Here, check this diagram with me. Here, extracellular, 2%, intracellular, 96 to 98%, and there is potassium channels between the intracellular and the extracellular, and sodium potassium ATPase-based channels. And how we can get rid of excess potassium? Here, through the colon, and we need this piece of information for the management later on, and also through the kidney. Here you can see with me the potassium homeostasis. Potassium is the kidney is the main regulator of the total body potassium in normal persons, and the plasma potassium is the poor indicator of the total body potassium. As I stated before, that it is only in the serum around 2% only of the total body potassium. Here, if you see intracellular fluid in intracellular volume, it is around 3,600 millimole, and only in the extracellular fluid, only 55 millimole, where the loss is mostly renal and based on some hormones and some other factors I will discuss later. So the renal loss of daily potassium is around 20 to 100, and the fecal loss is only 5 millimole per liter. How? It is dependent on what? It is dependent on potassium intake and load. If I will eating too much potassium containing food, depending on redistribution between extracellular and intracellular, and this is dependent on some hormones and acid-base status, and the output, as I stated before, urine can excrete, or the kidney can excrete 90% of the excess potassium, and gut and skin only 10%. Let's stop here with this diagram for a while. It is adapted from New England Journal of Medicine. As I told you before, I will start from the physiological background. Here, this is the glomerulus, proximal convoluted tubules, lobe of Henle, distal convoluted tubules, and this is collecting ducts. Between the distal convoluted tubules and glomerulus, there is a juxtaglomerular apparatus, where the afferent arteriole and distal convoluted tubules make an interchange that is affected by many factors, like we'll see. Here, the potassium balance is based on, at the end, by the RASI. RASI, I mean renin, angiotensin, aldosterone system. Okay, so let's start with renin. Renin is being released from this apparatus, the juxtaglomerular apparatus. So if any impairment in renin release with non-steroidal use, beta blocker, cyclosporine, tacrolimus, or diabetes or elderly, or renal ischemia, or renal hypoperfusion, so here we will have affection in the renin. And also we have aliskiren, which is a direct renin inhibitor. It stopped the renin action on the angiotensin 1 conversion to angiotensin 2. And again, angiotensin 2 blockers may stop the conversion between angiotensin 1 to angiotensin 2. And here the angiotensin will work on in the adrenal gland to release aldosterone. So if I am using some drugs that may impair the aldosterone release, like if we have an adrenal disease, heparin or ketoconazole, this will be affected. Also, if I will have aldosterone receptor blocker like spironolactone, ipilimumab, or drospirenone, it will affect this mechanism. So the main issue here is working on this potassium and sodium channels. So if I will make an impairment in this process, at the end here, potassium will not be released in urine and will be retained in the body, causing the hyperkalemia. Why this is the most important? Because as I told before, 90% of excretion of potassium, excess potassium in our body is dependent on the renal and urine loss. Here on the microscopical view, we see distal convoluted tubule part 1 and 2 and the collecting duct, where all these channels work in harmony. NCC and ENaC and ROMC and MAXI-K work on excretion of potassium, and any change in the aldosterone receptors, either blocking the aldosterone or the aldosterone receptor itself, will cause hyperkalemia. So what is the functions of potassium in our body? Why we care about potassium, whether it is low or high or in the normal? Potassium maintains cellular hemostasis. It maintains the heart function, skeletal contraction and smooth muscle contraction, nerve impulse transmission, and also enzyme function, protein synthesis, DNA synthesis, and apoptosis. If we have hypokalemia, it is dangerous and life-threatening. If we have hyperkalemia, it has the same potential of being fatal. So by definition, hyperkalemia is typically defined as serum potassium over 5 millimole per liter or milliequivalent per liter, and it can be further classified into mild, moderate, and severe. Mild from 5 to 5.5, and moderate from 5.5 to 6, and severe is over 6. So if I want to diagnose hyperkalemia, we have a problem in the diagnosis. Why? Because we have sampling problem, and we have to detect where is the fatal effect, how we will detect this early. So hyperkalemia has been called the most dangerous acute electrolyte abnormality because it may lead to life-threatening cardiac arrhythmia and death. Hyperkalemia is often asymptomatic, especially if it is mild, especially if it is chronic, especially if it is gradually accumulating. Symptoms may be non-specific, like fatigue, weakness, muscle weakness, palpitation, GI abnormalities, cardiac abnormalities, neurological abnormalities. Symptoms may vary from patient to patient, as I told you, between patients who have rapid accumulation and the patient who have gradual accumulation. So ECG changes, why I care about hyperkalemia. And when I say this is dangerous hyperkalemia, when I have an ECG changes. So ECG changes, let's check together. This is the normokalemia or the normal ECG, P, QRS complex, ST segment, and the T wave and D wave. You see, this is all the normal. Let's get accommodated with this picture because we will compare. Here's the hyperkalemia, the mild will start to have high peaked T wave, as you see here. This is very important for all of us. So when we will see an ECG like this, we have to measure the potassium, and if it is suspected, we have to go through and give calcium as a protection for this patient. Severe hyperkalemia, you will have more prolongation in BR interval, depress the ST segment, and the heart rate function slows. And this is the fatal one, ventricular fibrillation, and may progress to asystole and sine wave pattern. So, dangerous hyperkalemia, fatal, life-threatening. So it comes to my mind, why don't I use ECG as a diagnostic test for hyperkalemia? I stated in the beginning, maybe I will take a sample for potassium, and it is wrong sampling. It will be sent late, very late to the laboratories. In the labs, there is a problem in the machine or something, so it will be fake hyperkalemia. So why don't I go through ECG as a diagnostic test, even in the ER? Can I do this? Because previously, some people were thinking about this. If I have a patient with suspected hyperkalemia, and I am suspecting that he's having hyperkalemia, as I will mention in the causes, so I will do ECG. Why don't I do ECG? Let's see why we cannot depend only on ECG. Because ECG has poor sensitivity and poor specificity for hyperkalemia. If we will find, these are 3 studies. We found that in 127 patients, the serum potassium were between 6 and 9.3, and only 46% of those patients have typical ECG changes. And in 90 cases in another study, only 24 noted to have the characteristic T wave changes. And in 1/14 who presented with arrhythmia or cardiac arrest had the strict criteria, but 13 out of 14 didn't have this strict criteria. So ECG is important to detect and follow up the effect of potassium on the cardiac muscle, but it cannot be used as in diagnosis. It cannot be used as a diagnostic test. We have to depend on the serum and take precautions, the usual precautions for diagnosis. I am sorry for this interruption. So, as I stated before, hypokalemia is dangerous, and also hyperkalemia is considered a silent killer. In the previous slide, we said that ECG cannot be used alone. I only can use ECG to say that this is dangerous and fatal hyperkalemia, just to give calcium gluconate or calcium chloride as soon as possible and monitor by the ECG. So I have ECG changes. I can give the calcium and monitor the ECG changes to revert these ECG changes and to take a decision whether to repeat the calcium gluconate again or not, and also to give other treatment to decrease the potassium. Here, let's see here the hypokalemia and the hyperkalemia. The normal calcium is between 3.5 to 5. So below 3.5, we will see that some control groups and diabetic and chronic kidney disease, heart failure and in diabetes. So in control group, hypokalemia increase the predicted probability of mortality, but with other comorbidity, the mortality predicted probability will increase in a significant way. It will be with diabetes only. You see this yellow line, it is increased. And if this patient is diabetic and heart failure and chronic kidney disease, it reaches up to 0.5. And this is very dangerous. In the same way, hyperkalemia is dangerous either in patients who have no problem at all, or in other patients who have diabetes, chronic kidney disease, heart failure, and diabetes. And whenever you have more comorbidity, the potassium will affect more and may increase the mortality more. And here you see in this diagram that hyperkalemia is the leading risk factor for in-hospital mortality. Can you imagine that even the age over 75 may make probability of 2 only, and the hyperkalemia over 5.5 lead to more risk like 4. And even anemia or CKD, COPD, valvular disease, ischemic heart disease, all these factors, as you see, is less dangerous than presence of hyperkalemia. So if a patient with us and he had hyperkalemia, we have to mark him that he had hyperkalemia, and he has to be educated and to be put in his files that he suffered from one hyperkalemia. Why? Because this patient has a high risk of recurrence. The risk of recurrence for hyperkalemia is very high, and I will show you in the next slide. In this large retrospective study in CKD patients with or without CKD who experience hyperkalemia once are at a greater risk for recurrence. You see, more than 50% have recurrence of hyperkalemia within 1 year. 50% of these patients with hyperkalemia had 2 or more recurrence within 1 year, and some patients have up to more than 20 episodes of recurrence of hyperkalemia, and some of these episodes were life-threatening. What about the prevalence of hyperkalemia, especially in chronic kidney disease? Why I care about chronic kidney disease? Because 90% of the loss of potassium and the excretion of more potassium is through the kidney. So if the patient will have chronic kidney disease, he is the most one at risk for hyperkalemia. The prevalence is as high as 40 to 65% in chronic kidney disease, and even in some specialized clinic, the prevalence reach up to 55% with annual mortality 25%. What are the causes of hyperkalemia? I want to take a look here on pseudo-hyperkalemia, where hemolysis, delayed sample processing, and the severe leukocytosis and thrombocytosis is a cause of high potassium, but it is pseudo-hyperkalemia. We have to take care if a patient with hemolysis, or some patients may have hyperkalemia only for prolonged tourniquet before the venous sampling. Some issues, some causes are iatrogenic, as I stated in the first presentation, in the beginning of the presentation, like taking ACE inhibitor or ARBs or L-screen, working on the RASI axis, which is the renin, angiotensin, aldosterone system inhibitors. Beta blockers may cause hyperkalemia, potassium-sparing diuretics, some antibiotics, heparin, bagged RBC transfusion, especially if it has long storage, cyclosporine and tacrolimus and other CNIs, digoxin toxicity, DKA and hyperosmolar non-ketotic syndrome, and some cellular lysis like hematoma, rhabdomyolysis, hemolysis, tumor lysis syndrome, and the most important is the renal failure, oliguria with depressed GFR, and also type 4 renal tubular acidosis is a cause of hyperkalemia. Here, just to see where is the problem, hyperkalemia due to dysfunction in the RASI system. The potassium senses the hyperkalemia, secretes renin, and then renin stimulates angiotensin to be converted angiotensin 1 to angiotensin 2, and then stimulates the secretion of aldosterone. The aldosterone will work on the kidney to excrete more potassium. So in any impairment on any stage of this will cause the hyperkalemia, as we said before. If we will ask our patient to stop potassium food, can you see with me here? Where's the potassium? Potassium is everywhere. It is present in fruits, vegetables, and all other materials used for preservation. So you can see it here in the salt, in the salsa, and the beans. So it is very difficult for our patient to tell him stop eating potassium. But we have some foods with very high potassium, and we will talk about this later. So RASI treatments are the cornerstone and standard of care in heart failure and CKD patients. We agree together now, and we discussed it before together. You see many slides on this, that using some drugs working on the RASI in the RAS axis will make problems to our patient and may make hyperkalemia. But This is the cornerstone and standard of care on any patient with heart failure and chronic kidney disease. If you are internist or intensivist and you make consultation to the cardiologist or nephrologist, usually there is no prescription in cardiology and nephrology without S inhibitor or ARBs or spironolactone. So what we will do is these drugs are important. Yes, you can check here with these studies. With S inhibitors, we have the HOPE study and ZOLVIT study. You can see the number of the patients, 3,000 and 2,000. What is the benefit of using these S inhibitors in these studies? It was 25% reduction in combined outcome of MI, stroke, cardiovascular mortality in diabetic patients, and 16% reduction in heart failure-related hospital admission or mortality in patients with congestive heart failure. So we cannot stop S inhibitor in these patients, or even we cannot reduce the dose. Reducing the dose will make us out of the study recommendation for the dose that makes this benefit. ARBs also were examined in CHARM study, IDENT, and RENAL, and you can see how many patients shared in CHARM study, about 7,000. 16% reduction in cardiovascular mortality or heart failure hospitalization, 23% reduction in risk of end-stage renal disease in diabetic patients, and 20% reduction in risk of end-stage renal disease or mortality in diabetic nephropathy. And for mineralocorticoid receptor antibodies, antagonists like spironolactone, runs the study and emphasis study, there were 30% reduction in risk of mortality and 41% improvement in NIHA classification for these patients, and 35% lower frequency of hospitalization for worsening symptoms of heart failure, and 37% reduction in cardiovascular mortality or hospitalization. So again, why I am saying this? To elaborate more and to convince you that these medications are very important and we cannot stop or reduce the dose. In these studies, using S inhibitor or ARBs or spironolactone, let's see, this is the outcome, as I stated before, this is the benefits, and this is the hyperkalemia rate. Look to this area of the schedule. You can see that hyperkalemic rates were 38%, 11%, 18%, 13%. So it is highly prevalent in these patients with this comorbidities and using these drugs. And you can see here how many percent of patients who maintained or reduced or discontinued RAS inhibition therapy. 52% maintained only the RAS dose, and 16% reduced the dose, and 22% stopped the dose. And this is only if the potassium reached to the margin of 5.4. But if it reached more than 5.5, 41% only maintained the dose, and 21% only reduced the dose, and 26% stopped the dose. Stopping or reduction, as I stated before, we will lose the benefits of reduction in mortality and reduction of morbidities. So let's see this slide. I have RASI that is associated with better clinical outcome. I have physician who is down titrating or stopping the RASI due to hyperkalemia, and this leading to consistently to worse patient outcome again. And I am thinking about a new option that enable us as a physician to give the RASI blockers or the RASI drugs without reducing or stopping the dose because of hyperkalemia. And now we will start talking about management of chronic hyperkalemia. In acute hyperkalemia, we all know how to manage it, but in chronic hyperkalemia, how we will manage? We will talk about potassium. Potassium in diet range from 50 to 75 milli equivalent per day. Potassium is a common ingredient in many food. It restricts consumptions. With restriction of consumption of some healthy food, potassium may be reduced. RASI reduction limits the dose or discontinue treatment of drugs known to be effective in this population. If we will reduce or stop the RASI, okay, potassium will be controlled, but this is not what we want. Or use of non-potassium sparing diuretics like like thiazide or furosemide, or use of these drugs or powders, SBS and CBS, that use the gastrointestinal tract to reduce the potassium. So again, this is the high potassium foods. It is more prevalent in banana and dates, and this is the most fruits we have to avoid. So for the first drug, the SBS, sodium polystyrene sulfonate, it is an insoluble polymer, cation exchange resin, and after ingestion of the oral formulary or application it through the rectal route, this resin exchanges potassium with sodium, and we get rid of the potassium through the gastrointestinal tract. But what is the side effects of this drug? It may cause nausea, vomiting, diarrhea, and loss of appetite. And serious side effects is ischemic colonic necrosis, especially with using sorbitol, and constipation, seizures, confusion, some muscle weakness, some issues that is related to hypokalemia itself as an overdose, or even with the normal dose, one of the side effects of is hypokalemia. Calcium exchange resin or calcium resonium, it is the calcium polystyrene sulfonate. It's different from the first one in that this is based on calcium and the other is based on sodium. It has the same rules in being used as oral or rectal, and we can use it in a dose of 15 grams 3 to 4 times per day, and each dose should be given in a suspension of small sip of water. For greater palatability, can use a juice, but potassium-free juice. And we can administer this calcium resonium at least 3 hours before or 3 hours after oral medication. As an exchange resin, it can combine with other drugs, and this is one of the drawbacks of these drugs. Rectal route is preferable in some patients with gastroparesis. Keep in mind that most of our patients are diabetic and have gastroparesis. And also it can be used if the patient is suffering from vomiting, if he's suffering from uremic symptoms. Contraindications are in patients with potassium, plasma potassium less than 5, because it may cause hypokalemia, and caution with hypercalcemia because it is based already on calcium, and some patients have hypersensitivity to polystyrene sulfonate. The most important side effects here, as I stated here, the hypokalemia and the some electrolyte imbalance like hypomagnesemia and hypercalcemia. Then the other drug is zirconium cyclosilicate. It is microporous zirconium silicate compound. It is insoluble and highly stable. Actually, it is not yet in the market, but it has 9.3 times more potassium binding capacity than kayexalate or sorbistrate or the SPS, and more than 125 times more selective for potassium than SPS. So highly selective and highly sensitive and higher binding capacity, but unfortunately it is not yet in the market. And here we will talk about Batiromer. This is a new drug, same powder based, and it works the same like calcium polystyrene sulfonate. It is orally administered and doesn't bind with dietary potassium at all, and it works in the large intestine to get rid of the potassium, as we see here. Batiromer is Batiromer sorbitex calcium, non-absorbed cation exchange polymer, and orally administered. And you see here the component of it. And one of the good effects that it works in the physiological pH of the colon. Here it doesn't combine with any dietary potassium, and it works only in the colon. Now I will talk about some trials about its efficacy and safety. Here, the BIRL-HF trial, where there is evaluation for the efficacy and safety of Batiromer in patients with chronic heart failure. This study, excuse me for a minute. I'm sorry for this interruption. So, in this study, Batirumab was used versus against placebo and Batirumab. In the upper line, this is the placebo, and in the lower line, this is Batirumab. These patients were heart failure and they needed to have spironolactone, and they use in the beginning of the 8 weeks, they started with 25 milligram per day of spironolactone, and then in the 4th week we added another 25 to make it 50 milligram per day. And you can see here in the lower line of Batirumab, all patients were maintained potassium in the target level, and in the upper one, the placebo, potassium was high, not high enough to cause a problem, but high enough to be on the margin. But this is about the efficacy, and it was efficient. The other trial is AMSIST-DN trial. It was used to detect the efficacy of this drug in diabetic patients and diabetic kidney disease. Patient with CKD 3 and 4, and they are diabetic with diabetes with albuminuria. This is the inclusion criteria, and they had to take S inhibitor or RASI dose, and they suffered already from mild to moderate hyperkalemia. Here we have 3 cohorts. The first one, we started the screening, as I said, CKD stage 3 and 4, and type 2 diabetes. Here we stop the original RASI and give losartan 100 milligram per deciliter per day, and the other cohort, we continue on the same RASI, but we added on it spironolactone 25. And the other cohort, those patients didn't suffer from albuminuria, and we added and we maintained the same RASI. Here we started these doses 4.2, 8.4, 12.6, and on the other side, for moderate hyperkalemia, we give 8.4, 12.6, 16.8. And we titrate the dose. The most important in this study, it is not only for 4 or 8 weeks, no, it is for 52 weeks. You can imagine these patients take Batirumab for 1 year without a problem. And here we can see that most of our patients didn't suffer from any hyperkalemia, and by week 52, we didn't suffer from any problem. But if you notice this rise in the curve, this is after the 52 weeks in the next year, and we didn't have any other issues. For the efficacy and safety and tolerability of Batirumab, we have OPAL study, where we have a phase 3 randomized control study. We use CKD stage 3 and 4. We use RASI therapy, and the potassium was between 5.1 and 6. Again, we can see that the difference between the dotted line of placebo and the Batirumab line, it is much different with high efficacy for Batirumab. And here in the side effects, we didn't suffer from hypokalemia if we compare with SBS or CBS. The usual dose is 8.4, and 90% of those patients who were maintained on Batirumab for the last 2 years didn't suffer from any serious side effects. So Batirumab can save us from dangerous hyperkalemia and allow us to use beta blocker, S inhibitor, and ARBs, and even anti-mineralocorticoid drugs. We have 2 cases, and for the first case, female patient, 30 years old, has been on dialysis for the last 10 years, and she's known lupus and antiphospholipid, and came for our hospital with management of failed vascular access. She couldn't do dialysis for the last 10 days. She has a superior vena cava thrombosis and a bilateral femoral vein thrombosis, and we couldn't insert a hemodialysis catheter. And she's referred to us for insertion of translumbar or transhepatic. And also the patient refused peritoneal dialysis. So off-label, we used Batirumab in a dose of 25 grams, and the potassium was 6.6, and even we suffer from hyperkalemic changes. And with use of Batirumab and calcium to reverse the hyperkalemia, you can see that follow-up after 6 hours is potassium is 5.8, and after 12 hours it is 5.4. Here's the other case, 52 years old man, male, long-standing diabetes, chronic kidney disease, heart failure, and Epstein anomaly, on conservative management, and he's refusing dialysis. He is maintained on metoprolol as a beta blocker, 50 milligram once daily, irbesartan 300 milligram once daily, and metolazone as thiazide diuretic, 2.5 milligram once daily. Initially, the patient was orthopneic, blood pressure was okay. He has ascites, moderate ascites, and lower limb edema up to the knees. His potassium was 6, and as I stated, he is refusing dialysis. Revised dialysis, revised diet, revised sampling procedure, and still his potassium is high. So what will be the recommendation? Giving dialysis, he's refusing. Increasing the dose of Lasix or adding potassium exchange resin. As the patient was refusing dialysis, we start giving Lasix in higher doses, like 250 once daily. And we maintained the patient, and the potassium was low as 4.5, but the patient started to have confusion because he suffered from hyponatremia due to use of overdose of diuretics. So we started giving him hypertonic saline with much improvement of his conscious level, but we suffered from pulmonary congestion and overload. So we started dialysis, and the patient was discharged after stopping dialysis. And later on, we added this batiromere or potassium exchange resin, and his case was controlled with normal sodium and potassium. And after 6 months, still the patient is maintained with anti-hyperkalemic measures, and he didn't use to start dialysis again. Thank you. So for the question of batiromere in chronic renal failure, it is off-label use. It is not yet recommended for using batiromere in chronic renal failure or end-stage renal disease. ACE inhibitor and ARBs, at any stage should we stop? This is the second question. Actually, it is this question needs a lecture to say when we can stop. I can state that ACE inhibitor and ARBs are not nephrotoxic. We can use it as a renal protection drugs, but at one stage or more, we have to stop at the end because of some side effects like hyperkalemia. Okay, thank you. And now we will have the next presentation on resolving pneumonia. It will be presented by Dr. Rasha Hindi, our pulmonology consultant.
Welcome, inshallah. I will talk about unresolving. Okay, good evening. Inshallah, I will speak about unresolving pneumonia.
اللي ظاهر المحاضرة القديمة.
المحاضرة القديمة بتاعتك؟
ممكن.
ده الغلط بتاعي؟
لا مش وصل عشان كده.
خلاص. Okay. Good evening. Inshallah, I will talk about unresolving pneumonia. You have to know first that unresolving pneumonia is a common problem faced by physicians, and it is responsible for 15% of pulmonary consultation needing hospital admissions and bronchoscopies. One minute, please. لا اوكي. ايوه انا اللي مش ظاهر عندي، انا اللي نسخه. So, non-resolving pneumonia is responsible for 15% of pulmonary consultation needing hospitalization and 8% of bronchoscopies. 9% of community-acquired pneumonia and 60% of hospital-acquired pneumonia show inadequate responses to empirical therapy initiated. There are a variety of reasons that a case of pneumonia might resolve slowly or incompletely, including those relating to the etiology and those relating to host and development of complications from infection. In addition, non-infectious etiologies of pulmonary infiltrate can mimic infectious pneumonia, thus making it appear that resolution is not following the expected course. Approximately 20% of presumed non-responding pneumonia is due to non-infectious causes. The rate of resolution of pneumonia not easily defined and may vary depending upon the underlying cause. Patients typically note subjective improvement within 3 to 5 days of treatment. A more specific clinical criteria for resolution include improvement in tachycardia and hypotension within 2 days, fever, tachypnea, arterial oxygen saturation expected to improve within 3 days, cough and fatigue, which may take 14 days or longer to improve. British Thoracic Society guidelines for management of community-acquired pneumonia suggest that chest radiograph and hospitalization be considered for outpatients with pneumonia who fail to improve after 48 hours of treatment. Most studies on the natural history of pneumonia have focused upon resolution of chest radiographic abnormalities, with this low resolution often being defined as persistent of radiographic abnormalities for greater than 1 month in clinically improved hosts. Determining whether a patient has a non-resolving or progressive pneumonia must also take into account several factors that affected the expected rate of resolution, and these include comorbidities, age, severity, and infectious agent. The comorbidities associated with delayed resolution of pneumonia include a variety of diseases like chronic obstructive pulmonary disease, alcohol use, neurological disease, heart failure, chronic kidney disease, malignancy, HIV, and diabetes mellitus. Each makes some problems for the immune response of the patient. 90% of patients younger than 50 years of age show radiographic resolution by 4 weeks, compared with only 30% of patients older than 50, even in absence of concurrent disease. Radiographic resolution of severe pneumonia is estimated at 10 weeks, compared with 3 to 4 weeks for mild to moderate pneumonia. The rate of radiographic and clinical improvement varies with particular infectious agent causing the pneumonia. Resolution is more rapid with Mycoplasma pneumoniae, non-bacteremic Streptococcus pneumoniae, Chlamydia species, and Moraxella catarrhalis than with other organisms. Evaluation of patients with apparent non-resolving pneumonia generally center around more detailed imaging studies and obtaining material for microbiologic and pathological analysis. The diagnostic evaluation of treatment failure in pneumonia begins with careful history and physical examination together with review of the medical record, whether or not the rate of resolution is within the range of expected norms, taking into account the patient underlying host factors, comorbidities, severity of illness, and suspected pathogen must be established. Stable or slowly improving pneumonia, especially in presence of comorbidities or host factors that are known to delay the resolution of pneumonia. Careful observation with or without therapy is warranted for 4 to 8 weeks. If there is no resolution or progression of disease, a more aggressive diagnostic approach is appropriate. It should include appropriate basic laboratory studies as used in initial diagnosis and chest CT to look for sequestrated areas of infection or finding that suggest an alternative diagnosis. When pneumonia fails to resolve or when there is a clinical progression, bronchoscopy should be considered. Patients with negative bronchoscopic examination have a good chance of having slowly resolving pneumonia, particularly if they are a smoker or over the age of 55. Diseases not readily or typically diagnosed with bronchoscopy include pulmonary vasculitis syndromes, bronchiolitis obliterans with organizing pneumonia, and diffuse alveolar damage of various etiologies. With a worsening chest radiograph, progressive symptoms accompanied by negative bronchoscopy, further evaluation with thoracoscopic or open lung biopsy may be necessary. Chest CT, particularly high-resolution CT, is the primary diagnostic tool for assessing treatment failure of peristaltic pneumonia. Compared with the conventional chest radiography, the high-resolution CT chest allows superior detection of parenchymal abnormalities, including emphysema, airspace disease, interstitial disease, and nodules. Such finding may narrow the differential diagnosis or suggest new possibilities not previously under consideration. Chest CT also detects sequestrated foci of infection like lung abscess and empyema and help direct biopsy procedures. Bronchoscopy with bronchoalveolar lavage and transbronchial biopsy can successfully diagnose approximately 90% of patients who eventually have a specific diagnosis established. It is more likely to be useful in younger non-smoking patients with multi-lobar involvement in prolonged disease. Whereas older adult patients, smoker, and those with immunodeficiency are more likely to have non-diagnostic bronchoscopy and to have slowly resolving pneumonia. Bronchoscopy is particularly useful to exclude mycobacteria or fungi if not detected with expectorated sputum. Development of endobronchial ultrasound has improved the value of bronchoscopy and should be considered as an alternative to mediastinoscopy when mediastinal lymph nodes are enlarged. Several factors need to be considered when deciding to proceed to more invasive biopsy procedures such as thoracoscopic or open lung biopsy. Previous non-diagnostic bronchoscopy concern about the specific patient risk or ability to tolerate bronchoscopy or the need for obtaining larger specimen of tissues for certain diagnosis may all support the need for proceeding to thoracoscopic or open lung biopsy. The rate of clinical and radiologic resolution of bacterial pneumonia varies depending upon specific bacterial pathogen. The empiric approach to treatment with community-acquired pneumonia and hospital-acquired pneumonia suggested, but most guidelines can result in failure to treat appropriately when pneumonia is a result of less common pathogens like anaerobes and fungi. Regarding Streptococcus pneumoniae, because it is the most common cause of community-acquired pneumonia, it is also responsible for most cases of non-resolving pneumonia syndromes that are due to infection. In normal individuals without predisposing illness, clinical improvement is relatively rapid and proceed radiographic improvement. Risk factors for delayed resolution of auscultatory finding and fever include more severe presentation, multi-lobar disease, and infection with drug-resistant organisms. Radiographic improvement is often much slower, with 20 to 30% of patients demonstrating non-radiographic improvement after 1 week. Initial worsening of chest radiograph is common. The risk factors for delayed radiographic resolution from Streptococcus pneumoniae include bacteremia, persistent fever, or leukocytosis beyond 6 days, advanced age, chronic obstructive pulmonary disease, alcoholism, and HIV. Radiographic clearance occurs by 1 to 3 months in non-bacteremic cases and 3 to 5 months in bacteremic cases. Residual radiographic abnormalities are rare in non-bacteremic cases, but are present in up to 35% of bacteremic cases. Another pathogen responsible for delayed resolution is Legionella, and many of the risk factors for development of the Legionella are also risk factors for delayed resolution, and these include cigarette smoking, alcoholism, age greater than 65, immune suppression, chronic kidney disease, hematopoietic stem cell transplantation. As a result, the rate of resolution for Legionella infection is usually slower than for other organisms. Radiographic, but not necessarily clinical deterioration despite treatment is common, occurring in up to 2/3 of patients with Legionella, compared with 4% of patients with non-bacteremic pneumococcal pneumonia. In addition, after this initial deterioration, resolution is slow, with clearing beginning only after 2 to 3 weeks, in approximately 1/2 of patients demonstrating residual abnormalities at 10 weeks. Resolution may take as long as 6 to 12 months, and residual fibrosis may be evident in up to 25% of the patient. Mycoplasma pneumoniae is a common cause of respiratory tract infection, but rare cause of severe pneumonia. Resolution is typically rapid and faster than that of other types of pneumonia. Significant clinical improvement usually occurs within the first 2 weeks, which may in part reflect the predominantly young and otherwise healthy population affected. Radiographic deterioration after treatment is rare, occurring up to or less than 25% of cases, and the average duration of radiographic abnormalities is 2 to 4 weeks, depending upon the use of antibiotics. Chlamydia pneumoniae infection is an uncommon cause of pneumonia, but it has implicated outbreaks of pneumonia in residents of long-term care facilities and military records. It is a relatively mild disease and mortality is rare. Imprompt resolution is a rule in younger patients. Radiographic deterioration uncommon, with clearing typically occurring in less than 3 months. Haemophilus influenza is commonly considered the cause of pneumonia, especially in older adults, in cigarette smoker, and in patients with chronic obstructive lung disease. Based on the propensity of the organism to infect immunocompromised and older adult, resolution is often slow, with many patients having prolonged hospitalization. Only 50% of patients return to their previous level of function by 6 weeks. COVID-19 pandemic has resulted in growing population of individuals recovering from acute SARS-CoV-2 infection. The recovery process from COVID-19 exists on a continuum. Early in the course of acute COVID-19, management is focused on detecting and treating the acute COVID-19 related complications, while after recovery from acute phase, some patients require evaluation and management for persistent or new symptoms. There are 3 stages for COVID-19 recovery, including acute COVID-19, ongoing symptomatic COVID-19, and post-COVID-19. Regarding acute COVID-19, means symptoms of COVID-19 for up to 4 weeks following the onset of illness. And ongoing symptomatic COVID-19 means symptoms of COVID-19 from 4 to 12 weeks following the onset of illness. And post-COVID-19 symptoms that develop during or after COVID-19 continue for equal or more than 12 weeks, not explained by alternative diagnosis. These stages reflect symptomatic recovery and are not related to active viral infection and infectivity. Patients recovering from COVID-19, particularly those with critical illness, may have additional symptoms similar to the syndromes experienced by patients recovering from other critical illnesses, which are known as post-intensive care syndrome, and these symptoms include physical symptoms, psychological, and cognitive symptoms. The common persistent physical symptoms including fatigue, dyspnea, chest pain or tightness, and cough. Less common persistent physical symptoms including anosmia, joint pain, headache, Secchi syndrome, rhinitis, poor appetite, dizziness, myalgia, insomnia, alopecia, sweating, and diarrhea. Psychological and cognitive complaints are also common during recovery from acute COVID-19 and may be seen more commonly than in those recovering from similar illnesses. In some studies, almost half of COVID-19 survivors reported worsened quality of life. 22% had anxiety and depression, and 23% of the patients were found to have persistent psychological symptoms at 3 months. Early data suggests a longer recovery course in patients requiring hospitalization, older patients with pre-existing comorbidities, patients who experienced medical complications like secondary bacterial pneumonia or venous thromboembolism, patients who had prolonged stay in hospital or ICU. However, subsequent data suggested that even patients with less severe disease who were never hospitalized, including those who self-reported COVID-19, have often reported prolonged and persistent symptoms. For hospitalized patients, data suggests that significant proportion of the patients who were admitted with acute COVID-19 experienced symptoms for at least 2 months following discharge. Most patients hospitalized with COVID-19 are successfully discharged, although approximately 10 to 20% require rehospitalization. The risk for rehospitalization included age equal or more than 65 years, discharge to skilled nursing facility or with home health services, presence of one or more comorbidities, body mass index equal or more than 30 kilogram per square meter. In one retrospective cohort of 1,409 patients admitted with COVID-19, 10% were hospitalized, and the risk of rehospitalization or death was higher among male patients, white patients, and those with heart failure, diabetes, frequent emergency department visits within the previous 6 months, daily pain, cognitive impairment, or functional dependency. In another study of 1,775 patients discharged following COVID-19, 20% were readmitted, and readmission was associated with older age. Common readmission diagnoses were COVID-19, sepsis, pneumonia, heart failure, and over 20% required ICU admission, and the mortality was 9%. Risk of readmission or death were highest during the first 10 days or following discharge. During initial follow-up evaluation, we obtained comprehensive history of the patient acute COVID-19 illness, including illness timeline, duration and severity of symptoms, types and severity of complications, including venous thromboembolism, presence and degree of kidney injury, supplemental oxygen requirement, including the need for non-invasive or invasive ventilation, cardiac complication, delirium, and COVID-19 testing results and treatment strategies. We should verify the information with hospital records and review the discharge medication list with the patient to confirm accuracy. You have to do general laboratory testing, and the need for this testing in patients who recover from acute COVID-19 is determined by the severity and abnormal result during their acute illness and current symptoms. For most patients who have recovered from mild acute COVID-19, laboratory testing is not necessary. For patients recovering from more severe illness, those with identified laboratory abnormalities, patients who were discharged from hospital or inpatient rehabilitation facility, or for those with unexplained continuing symptoms, it is reasonable to obtain the following: CBC, blood chemistries including electrolytes and blood urea nitrogen, serum creatinine, liver function including serum albumin. Additional laboratory testing that might be appropriate for selected patients include prenatriuretic peptide and troponin in patients whose course was complicated by heart failure or myocarditis, D-dimer in patients with unexplained persistent unexplained persistent dyspnea, or in any patient in whom there is a concern for thromboembolic disease. Thyroid studies in those with unexplained fatigue or weakness, antinuclear antibody and creatine kinase in patients with arthralgia, myalgia, or other symptoms concerning for rheumatological disorders. There is no clinical utility in obtaining SARS-CoV-2 serology antibodies in patients who had their acute infection documented by positive molecular test or antigen test. However, for patients with period COVID-19 based upon symptoms but without documented positive molecular or antigen test, the value of obtaining SARS-CoV serology is unclear. Regardless, we sometimes obtain serology to guide additional testing or decision-making like convalescent plasma donation, evaluating unexplained symptoms. We typically follow all hospitalized patients within 1 week of discharge. For patients who are not hospitalized but who are older or have comorbidities, we should follow up within 3 weeks. We not typically evaluate patients with mild acute COVID-19 disease unless they have new persistent or progressive symptoms. During initial follow-up evaluation, we obtain comprehensive history of the patient COVID-19 illness, including illness timeline, duration and severity of symptoms, types and severity of complication, COVID-19 testing, and any management strategies. The need for laboratory testing is determined by illness severity, period abnormal testing during their illness, current symptoms, and we shouldn't routinely retest patients with active infection of SARS-CoV-2 at the time of follow-up outpatient evaluation. We have to perform comprehensive cardiopulmonary evaluation, including comprehensive history and physical examination. We should inquire about ongoing dyspnea, cough, chest discomfort, thoracic pain, wheezing and orthopnea, chest pain, peripheral edema, palpitation, dizziness, orthostasis, and pre-syncope or syncope. Based on clinical history and finding, cardiopulmonary testing strategy is appropriate. For all patients who had pulmonary infiltrate or other abnormality identified on imaging during acute course of COVID-19 illness, we obtain follow-up chest imaging, typically chest radiography at 12 weeks. For patients with new or progressive symptoms, earlier imaging is indicated. CT is preferred for patients in whom another etiology like malignancy is suspected, and high-resolution CT is an appropriate imaging study for patients with suspected interstitial lung disease from severe pulmonary involvement like ARDS. For patients with intermittent or persistent cardiopulmonary symptoms, including palpitation or those with generalized constitutional complaints like weakness or fatigue, we typically perform 12-lead ECG. We shouldn't routinely perform transthoracic echocardiography. However, we have a low threshold to obtain transthoracic echocardiography in patients with a history or biochemical evidence of myocardial injury or myocarditis, or in patients with dyspnea and other signs and symptoms suggesting of potential cardiac disorders. For patients with persistent, progressive, or new respiratory symptoms and patients recovering from ARDS, we obtain pulmonary function tests, including spirometry, lung volumes, and diffusion capacity, together with 6-minute walk test. As regarding hypercoagulability, we have to evaluate all patients for signs and symptoms of deep venous thrombosis of upper and lower extremities, pulmonary embolism, or arterial thrombosis. For patients taking anticoagulant, we review the duration and indication for anticoagulation, confirming appropriateness and safety. Patients with documented thrombosis are treated in similar fashion to thrombosis in non-COVID-19 patients. Regarding olfactory and gustatory symptoms, in most cases, these symptoms resolve slowly over several weeks and don't require intervention except for education regarding food and home safety. And patients with persistent gustatory or olfactory dysfunction, we have to refer to test and smell clinic. The ability of the patient to return work or exercise should be assessed on an individual basis and will likely vary depending upon their baseline pre-COVID functional status and the severity of acute illness, as well as the type and the severity of complication experienced by the patient. In general, patient planning to return to high-level sport or physically demanding occupation following myocarditis should be first evaluated by cardiologist. As we talk about the causes of slowly or non-resolving pneumonia, we told that there is factors related to the organism and factors related to the patient and complication. Continuing the rule of pathogen, also misdiagnosis of pathogen can contribute to non-resolving pneumonia. Regarding tuberculosis, clinical presentation of tuberculosis as a cause of non-resolving pneumonia is often atypical, especially in diabetics and in older adult patients who commonly have radiographic finding in the middle or the lower lung zone. Diagnosis may be difficult as a sputum not always available, and culture results take weeks. And culture results take weeks. And culture results take weeks after a specimen is obtained. PCR testing have approved for smear positive specimen to allow confirmation of tuberculous disease, but its role in smear negative is uncertain. Both opportunistic and endemic fungal infection can mimic bacterial pneumonia and may present with rounded or mass-like densities with or without cavitation. And the patients with apparent non-resolving pneumonia, aspergillus is particularly important pathogen, presenting either as chronic necrotizing or as invasive aspergillosis. Patients with advanced AIDS are at increased risk of invasive aspergillosis, while patients with less advanced disease may develop tracheobronchitis. Although invasive aspergillosis classically occur in neutropenic patients who have been on multiple antibiotics for several days, it is increasingly recognized in older adult patients with chronic lung disease who are on corticosteroids. Endemic fungal infections such as histoplasmosis, coccidomycosis, plastomycosis, and cryptococcosis should be considered as a cause of non-resolving pneumonia in appropriate endemic areas. Although nocardia and actinomyces are higher order bacteria, the clinical presentation of infection due to these organisms is more consistent with fungal etiology. Nocardia infection present most commonly on chest radiograph as a localized alveolar infiltrate that's usually homogeneous, non-segmental, and cavitary. Infection due to actinomyces has similar appearance, but with propensity to extend across fissures and invade the chest wall. Again, we will talk about the factors related to pathogens. Some pathogens are resistant. Presence of resistant pathogen is an important consideration for any pneumonia that's not responding appropriately to antibiotic therapy. Although penicillin-resistant Streptococcus pneumoniae is the organism of most concern, multi-drug-resistant Haemophilus influenza, Pseudomonas aeruginosa, and as well as MRSA are increasingly recognized in the community setting as a possible causes of non-resolving or recurrent pneumonia. Now we have to talk about the host factor. There are many factors which may be associated with delayed resolution of pneumonia, including alcoholism, older age, and presence of comorbidities like diabetes and COPD. In addition, disorders of immune function, particularly AIDS and syndromes associated with deficient humoral immunity, can be associated with delayed resolution of pneumonia. Regarding AIDS, although unrecognized, pneumocystis jirovecii pneumonia remain an important diagnostic consideration. A patient with AIDS and CD4 count less than 200 cells per cubic millimeter. Still, the most common initial lower respiratory tract infection in this patient population remain bacterial pneumonia, especially pneumococcal pneumonia. Primary humoral immune deficiencies. It is important to identify these abnormalities as underlying risk factors for pneumonia because of the effect of treatment of intravenous immunoglobulin on the incidence and the resolution of pneumonia. Specific disorders commonly associated with hypogammaglobulinemia include X-linked gammaglobulinemia, common variable immunodeficiency, and selective immunoglobulin subset deficiency. And the most common pathogens in these patients include Streptococcus pneumoniae, Haemophilus influenza, with Mycoplasma pneumoniae and Pneumocystis jirovecii being the least common. We have to talk about the third factor in non-resolving pneumonia, which is development of complication from the initial pneumonia. Sequestrated foci of infection may prevent adequate concentrations of the antibiotic agent from reaching the site of infection. The two main forms of sequestrated focus preventing adequate resolution of pneumonia are empyema and lung abscess. Evaluation of possible empyema is initially facilitated by imaging techniques like CT and ultrasound. In patients with non-resolving pneumonia, demonstration of any significant amount of pleural fluid should prompt consideration of diagnostic thoracentesis to rule out pneumonia. Regarding lung abscess, anaerobes are the dominant flora of upper airways and common pathogens in aspiration pneumonia and acutely necrotizing pneumonia and lung abscess. The major pathogens in lung abscess are Peptostreptococcus species, bacteroids, and Fusobacterium. These infections are often mild in onset and relatively slow in progression. Patients typically present with fever, night sweat, weight loss, cough, dyspnea, and petrosputum with or without pleurisy. Predisposing factors that should raise the suspicion of abscess formation include alcoholism, seizures or poor dental hygiene, and previous aspiration. Chest radiography typically demonstrates an air liquid level in independent segment, but chest CT is more sensitive and can confirm the diagnosis in difficult cases. Many patients with lung abscess do well with conservative management and prolonged course of antibiotics. However, several factors are associated with increased abscess-related mortality and may warrant more aggressive approach. These include age-related factors like pediatrics or older adults, large cavity size, longer duration of symptoms period to therapy, lower lobe location, association with malignant disease, and presence of multiple abscesses, development of infection pre-existing only may be mistaken for lung cancer. Now we have to talk about the non-infectious etiology, which can mimic pneumonia and misinterpreted as non-resolving pneumonia. These fall in the following categories: neoplastic, inflammatory, drug-induced, and vascular. Some of these non-infectious etiologies may also associated with non-resolving pneumonia through other pathophysiological mechanisms like endobronchial obstruction by bronchogenic carcinoma. Neoplasms may be associated with non-resolving pneumonia either by compromising the airway lumen and secondary post-obstructive pneumonia or abscess, or by mimicking infiltrated porosis. Bronchogenic carcinoma and carcinoid tumor are the most common cause of endobronchial obstruction leading to pneumonia, whereas bronchoalveolar cell carcinoma and lymphoma are the most common causes of alveolar infiltrate mimicking pneumonia. Bronchogenic carcinoma compromises the airway either through endobronchial involvement or extrinsic compression. However, the frequency of endobronchial carcinoma as the cause of non-resolving pneumonia is relatively low, ranging from 0 to 8% in most cases. Endobronchial obstruction by carcinoid tumor is an important predisposing factor for post-obstructive pneumonia and should be considered as a possible etiology for endobronchial obstruction in young or non-smoking patients. Lung adenocarcinoma may present as focal infiltrate, often with air bronchogram and ground glass infiltrate with subsolid appearance, thus mimicking the radiographic appearance of pneumonia. Patients with bronchoalveolar cell carcinoma may present with discrepancy between the size of the infiltrate and the paucity of systemic symptoms. Lymphoma in the lung may also present with focal infiltrate with air bronchogram mimicking radiographic appearance of pneumonia. Lymphoma affected the lung parenchyma may occur either as a part of systemic disease or primary pulmonary lymphoma. There are three categories of clonal lymphoid proliferation are now recognized as producing pulmonary parenchymal involvement: low-grade B-cell lymphoma arising from mucosal tissue, high-grade B-cell lymphoma, and lymphomatoid granulomatosis. Primary pulmonary lymphoma is unusual, with only 10% of Hodgkin lymphoma and 4% of non-Hodgkin lymphoma presenting with alveolar infiltrate. As the disease progresses, lung involvement becomes more common, occurring in 38% of patients with Hodgkin lymphoma and 24% of non-Hodgkin lymphoma. Tricity may be particularly useful in patients with suspected Hodgkin lymphoma since mediastinal lymphadenopathy is common. Regarding inflammatory disorders, they can mimic and can be misdiagnosed as asthma because these disorders don't respond to antibiotics. They should be considered in the evaluation of patients with apparently non-resolving pneumonia. Systemic vasculitis or rheumatic disease may cause fever, dyspnea, and pulmonary infiltrate, and therefore can be easily mistaken for pneumonia. Granulomatosis, polyangiitis, and alveolar hemorrhage syndromes are the most frequent vasculitis to mimic pneumonia. Bronchoscopy and bronchoalveolar lavage are useful to establish diagnosis of alveolar hemorrhage. This is a patient with acute myelogenous leukemia and severe thrombocytopenia, and this is a picture of alveolar hemorrhage, which mimicking pneumonia and can be diagnosed easily with bronchoscopy. If you talk about cryptogenic organizing pneumonia, it is present with subacute onset with 75% of patients having symptoms less than 2 months at the time of diagnosis. Idiopathic bronchiolitis obliterans organizing pneumonia usually begin with flu-like illness mimicking atypical pneumonia with fever, malaise, fatigue, dyspnea, and dry cough. Patients may have elevated sedimentation rate and leukocytosis. Patchy alveolar infiltrates are typically present on the chest radiograph, often mimicking pneumonia. Regarding eosinophilic pneumonia, both chronic and acute can be characterized by collection of eosinophils in the interstitial and alveolar spaces. Chronic eosinophilic pneumonia typically present is subacute illness with cough, fever, dyspnea, weight loss, wheezing, night sweat, and radiographic infiltrate appearing over weeks to months. And chest radiograph often demonstrate patchy non-segmental alveolar infiltrate that predominantly affect the periphery of the lung, sparing the central and basilar region, and is called negative mirror image. Patients typically have rapid clinical and radiographic response to treatment with corticosteroids. Acute eosinophilic pneumonia has a more rapid onset of fever, non-productive cough, dyspnea, and pleuritic chest pain. And chest radiograph early in the course may show only mild reticular or ground glass infiltrates, which can progress to bilateral alveolar disease and ARDS. As in chronic eosinophilic pneumonia, response to corticosteroid is often dramatic. If we talk about pulmonary alveolar proteinosis, it's a rare lung disease characterized by abnormal accumulation of lipoproteinaceous fluid in the distal air spaces. Patients typically present with insidious onset of dyspnea, fatigue, weight loss, and low-grade fever, and chest radiograph often demonstrate non-specific central alveolar opacity in the lower and the mid-lung zone with a sparing of the areas adjacent to the diaphragm and the heart. High-resolution CT chest commonly show crazy paving appearance characterized by ground glass pattern with thickening of the intralapilar and interlapilar septa to produce polygonal shapes. Sarcoidosis may be confused with non-resolving pneumonia. When patients have pulmonary parenchymal diseases without intrathoracic adenopathy and an absence of clinical apparently extrapulmonary involvement. If we talk about drug-induced lung disease, it can be confused with infectious pneumonia, and careful evaluation of medication history should be done in patients with apparent non-resolving pneumonia to rule out drug-related etiology. Amiodarone toxicity is particularly important mimic of non-resolving pneumonia as it may have acute presentation with focal alveolar infiltrate. Pulmonary embolism rarely mimic pneumonia. The infiltrates representing areas of pulmonary infarction which may take several weeks to resolve and are easily mistaken for slowly resolving pneumonia. Finally, hydrostatic pulmonary edema, unusual or focal radiographic pattern of this pulmonary edema can occasionally mimic pneumonia because pulmonary edema can have focal presentation limited to areas of increased perfusion, as in patients with bullous lung disease or mitral regurgitation. Because pulmonary edema appear most prominent in areas of maximal perfusion, patients with severe chronic obstructive pulmonary disease may manifest a symmetric pattern of pulmonary edema. Thank you. I want to remind again about causes of non-resolving pneumonia in short. Causes related to the organism, causes related to the host, and complication, and non-infectious causes of pneumonia.
These are questions. We'll start with the question sitting with Dr. Rasha.
طيب, for how long education indicated ago?
Yes, you start. Read the question.
For how long anticoagulant is indicated? Anticoagulant duration the same as the patient with non-COVID. If I will decide for a non-COVID patient to give the non-COVID patient with thromboembolism to give it for 3 months, 6 months, 1 year, this is the same rule of the usual thrombus. Course duration of antibiotics in pneumonia is variable according to the suspecting organisms. More usually we start with empirical antibiotics. It is usually can give effect in 5 to 7 days, but some organisms which are the multi-drug resistant organisms may require prolonged duration, more prolonged duration, and the lung abscess, even lung abscess complicating pneumonia, the duration of management extend according to the etiology or the specific organism.
Due to time factor, we will continue answering the rest of the questions after next presentation for Dr. Rasha, which will be at 8 o'clock, inshallah.
Okay.
Thank you.
Thank you very much.
We would like to thank Dr. Rasha for joining us today. Dr. Rasha is our consultant of pulmonology, and we apologize for disturbance in the schedule. Today we have Dr. Muhammad Al-Ghubain, Professor of Pulmonology, and we are proud that he accepted our invitation. Thank you, Dr. Muhammad.
السلام عليكم، مساء الخير.
حضرتك عامل ايه؟ اخبار حضرتك ايه؟
الله يخليك، تسلم ان شاء الله.
احنا اسفين يا دكتور محمد، معلش بنعتذر لك قدام الناس كده ان احنا تاخرنا عليك، بس ان شاء الله يعني احنا كلنا جاهزين. Dear guest, I am so happy that I am seeing 350 healthcare workers attending our presentations, and I am sure we will get great benefit of attending this presentation with our professor, Dr. Muhammad Al-Ghubain. Dr. Muhammad will give us today a presentation about management of acute asthma. This is the first one. And during the presentation, you can post your questions. I will be the moderator. I will read the questions, and then I will visit to Dr. Muhammad. Yes, we are start sharing now. Please stay with us. Thank you. شكرا يا دكتور محمد.
طيب السلام عليكم مساء الخير. Thank you, Dr. Ahmed, for nice invitations, and thank you for audience to be with us this evening. I know it's late, 7 o'clock, and prayer time as well, so please be patient with me. I'm going to talk about important and common problems in the emergency room and about the management of acute asthma, because I noticed that in many ER rooms, in many hospitals, that there is a mismanagement or not suboptimal management of asthma and acute exacerbation of asthma flare-up or flare-up of asthma. So basically, the guidelines and regulations and the recommendations of management of acute exacerbation of asthma is still not up to the standard in many hospitals. So I'm going to highlighting and I'm calling the most updated guidelines. And as you know, there is two guidelines. The international guideline for asthma is the GINA guidelines, is WHO guidelines. It's worldwide used, and we have the Saudi initiative for asthma guidelines, which was published this month, 2021, in Annals of Thoracic Medicine. So basically, there is very important concept about asthma exacerbation or asthma flare-up or acute asthma exacerbation in the emergency room, that a lot of people, they believe that patients with mild asthma, they don't have exacerbations because they have only mild symptoms or occasionals, and they have simple cough and mild shortness of breath on and off, and they never have exacerbation. But actually, they are, even with mild asthma patient, they are at risk of having serious adverse events. So regardless about the level of severity of asthma, any asthma patient at risk of having acute exacerbation, acute worsening of their asthma symptoms and serious adverse effects. So it's up to 37% of patient with adult patient with acute asthma, they have acute exacerbations. And even with mild asthma, around 16% of these patients with mild asthma, they may have something called near fatal asthma. So they have a life-threatening asthma requiring to the ICU admission. So don't underestimate the mild asthma patient, and you think that they don't have an acute exacerbation and they are not at risk of death even up to 20% of patients with mild asthma, they may die because of acute exacerbation. So any type or any severity level of asthma, they are at risk of exacerbations. And there is a very important point that the more you use SABA, short-acting beta agonist, Ventolin, the more the patient using of the short-acting beta agonist, the more risky of having acute exacerbation, because the overuse of SABA is associated with very high risk of mortality and morbidity. So this is a very, very poor sign that the patient is under-treated, under-controlled, and they have at risk of having any complications or even death. Because overusing of SABA lead to the beta receptor downregulations, and this is downregulation of the beta receptor lead to the decreased bronchoprotections, and this will get to rebound hyperresponsiveness. So eventually, overuse of SABA, the patient starts to have a tolerance, and he or she is not able to even respond to Ventolin or other type of short-acting beta agonists. So be careful, the patient using many doses or many inhaler, many puffs of the Ventolin. There are really very serious problems, and because of the tolerance of the SABA, and they are at risk of having acute exacerbations. And this is, of course, increased allergic response and increased eosinophilic air inflammations, and eventually acute exacerbation of their asthma. So please remember that if the patient is SABA dependent only and never been inhaled steroid and even have mild asthma, this is a serious problem, and they are at risk. They are at risk of having acute exacerbations and the presentation to the ER. So higher use of SABA is said to the adverse clinical outcome more than 3 canister per year, like 1.7 puff per day, associated with very high risk of emergency department presentations, and this is well-established study on 2012. So the patient, even using 1 puff per day over 1 year or 3 canister per year, this is very high risk of emergency visit. And if the patient dispensing more than 12 canister per year is associated with the risk of death. So more than 12 canister of SABA or phentoline, they are associated with risk of death in patient with asthma. So this is always keep in your mind, overuse of the SABA is very poor prognostic sign of the poor outcome of patient with asthma, even the mild asthma. So most patients actually, however, most patients who present to emergency room with acute asthma exacerbations, they're already having uncontrolled asthma. So the patient will have asthma who have controlled asthma. Usually they don't have exacerbation, they don't come to the emergency room. So if you see patient in the ER with acute asthma exacerbations, the bulk of them, they already have uncontrolled asthma for several weeks and even several months before their presentation to emergency room. And some of them, they have a brief history of near fatal asthma, and some of them, they are taking 3 or more medication or inhalers, and they have heavy user of the SABA, as I already mentioned, the frequent ER visits. So they already, those patients present to the ER with acute asthma, most of them already visit the ER before. They are wandering from different hospital, different clinic. They are uncontrolled asthma. They are undermanaged and under treated. So patients should be assessed to determine the severity of acute attack. So this is a study or data about asthma mortality per 1 million in United States from 1980 to 1999. And as you see, from its almost mortality rate is start to increasing from 1985 to mid-90s up to 20 patients per 1 million asthma patients, they die basically because of asthma exacerbations. And after that, the trend has been decreased a little bit, but it's still in the average from 15 to 20 deaths per 1 million asthma patients in the United States. They die because of acute asthma exacerbation. So asthma patients still they die. And they die in the ER, not at home, before they present to the hospital, in the ER or in the ICU. So please, you have to remember that underestimation of the asthma exacerbation, is going to lead to the poor outcome and exacerbations, and the patient may have high mortality and morbidity. And this again, ER visit for asthma, there is like millions and millions of ER visits per year to the emergency room in asthma. So it's very common problems. It's almost every night and every day. You see even more than 1 patient with asthma come to the emergency room. So it's a common problem. It's actually one of the commonest problems seen in the emergency room on primary care patient with coming with uncontrolled asthma, and they have acute exacerbations. So up to 1.5 million visit to the emergency room of asthma patient in 2000 United States they reported to present to emergency room. So 1.5 million ER visit in 1 year in United States because of asthma exacerbations. And so it's a very, very common problems. It's a daily admission, okay? And many hospitals in Saudi Arabia and many parts of the world, sometimes they admit 5, 6, even 10, 20 patients per night, either to the ward or to the ICU. So it's a very frequent and encountered problems in the ER or in primary care setting. So what is the consequence of severe acute asthma? Severe acute asthma, they get severe bronchospasm. And if you have severe bronchospasm, you are going to have severe fecal mismatch. Fecal mismatch lead to severe desaturation or hypoxia, and it's going to have shunt, and the patient has respiratory failure and type 2 respiratory failure, comatose, and eventually, if there is no interventions, patient will die. And this is because of a development of intrinsic PEEP or OT PEEP, because alveolar pressure exceeding that. So alveolar pressure and alveoli exceeding the atmospheric pressure at the end of the inspirations, and this will going to increase intracranial pressures, and they have paratrauma, and the patient eventually die because of the coma and increased intracranial pressure. The patient has hypoventilations, increased work breathing, and eventually you lose your patient if you don't interfere early. So please, if you see patient with acute exacerbation of asthma in the ER, the earlier you interfere, the better outcome. The more you delay the patient or manage the patient, if you are busy and there is many patients in the ER and they are overcrowded in the emergency room, and there is many patients with asthma patients, please don't delay asthma management in the ER, because the more you delay, the outcome is going to be poor, and you may lose your patient just because of delay management because of overcrowded ER or many patients in the emergency room. So please interfere early, give the patient treatment too early to stop complications, and it's going to be the end result is going to be a better outcome in the patient recovery. So the initial assessment of asthma or acute asthma, if you see patient in the emergency room or a primary care clinic, and even in your clinic, and the patient has uncontrolled or severe asthma, so you are going to classify them in 3 categories in the ER, either moderate or severe or life-threatening conditions. Moderate, basically, patient talking freezes or full sentence, so he's talking normally in the front of your eyes. So you ask him question, take history, he's respond to you, and he has no problem with talking. He's a little bit agitated, but he's alert, conscious, no neurological symptoms. Respiratory rate from 20 to 30. He may or may not use his accessory muscles. His heart rate less than 20, and he's maintaining normal oxygen saturation. His oxygen saturation in room air more than 92%, and his peak flow is 50 to 75% predicted. This is labeled for patient with moderate. So patient with moderate asthma in the ER, basically mild respiratory distress, mild using extra muscles, little bit tachycardia, but less than 120, normal oxygen saturations, and the peak flow, peak expiratory flow. Please remember, peak expiratory flow rate or peak flow, you have to do it for each patient coming to the emergency room with acute asthma flare-up. Please do peak expiratory flow rates, unless the patient is not able to do it because of not cooperative techniques problems, or he has his decreased level of consciousness. But if the patient is able to do it, please use it, because this is one of the indicators of a severity of asthma. In moderate acute asthma attack, the peak flow is usually from 50 to 75% of the predicted, while in severe asthma, the peak expiratory flow rate is usually from 30 to 50% of the predicted. And the severe category, severe acute asthma exacerbations, defined by the patients unable to complete the sentence. So he's not able to respond to you. He answers some questions not able to complete the sentence. So ask him questions, he answered by 1 or 2 words. Agitated, okay, but he's not comatose, of course. Agitated, irritated, his respiratory rate more than 30, using his accessory muscles, his heart rate more than 120, and his oxygen saturation in room air usually less than 92%. So he's hypoxic, tachycardic, tachypneic, using accessory muscles, agitated, unable to complete sentence. This is a definition of the severe acute asthma exacerbation of flare-up. So, and the heart rate is 120, more than 120 is severe, less than 120 is moderate. Respiratory rate more than 30 is severe, less than 30 is moderate. And peak expiratory flow rate, if it's less than 50% of the predicted, usually is severe. While life-threatening asthma, anything which is more severe than the symptom of a severe acute asthma flare-up. So unable to talk, confused, drowsy, comatose, respiratory rate more than 40 or 50, respiratory failure, using accessory muscles, heart rate more than 20, bradycardia, silent chest, severely hypoxic, respiratory oxygen saturation less than 90% in room air, and his CO2 normal or high, so he's start retaining CO2, and his peak flow expiratory flow rate less than 30% predicted if he's able to do it, and usually they're not able to do it in life-threatening conditions. So if you see life-threatening conditions, this is basically a patient, he's a type 2 respiratory failure, bending intubations, bending coma, confused, severely tachypneic, he's severely hypoxic, and basically he starts to retaining his CO2. However, if the patient has if there is overlap feature, if the patient has some feature of moderate, some feature of severe, so label your patient on the more severe symptoms. So if the patient is desatting, hypoxic, so this is either severe or life-threatening. Okay, if the patient has for example, respiratory rate more than 30, but his heart rate is than 120, this is severe acute asthma exacerbation. So always you have to go the severity index. So the patient more severe symptoms, the more acute asthma exacerbation. So the patient has some symptom from moderate box, but some symptom from severe or life-threatening. The patient has life-threatening or severe asthma attack. So you have to assess this patient. So basically, the assessment of the severity of asthma in the ER depend on history, physical examination, neurological assessment, vital sign, respiratory rate, okay, and heart rate, oxygen saturations, and peak flow. If you do these things, and then you assess your patient in which category you label your patient, because the management and decision of discharge of admission depend on the assessment of the patient, either moderate or severe or life-threatening asthma. The medications used in acute asthma attack. Oxygen is very, very important. Please remember, oxygen is treatment, is medications. Is not supportive or symptomatic treatment. Oxygen is a must, and every patient, his oxygen saturation is than 90% room air, you have to put him on oxygen. And oxygen is not only to increasing oxygen saturation to above 92%, but also to relieve the symptoms. So you have to give controlled concentrations of inspired oxygen to correct hypoxia, and always you are monitoring your patient by using pulse oximetry. So how much oxygen you deliver to your patient depend on his oxygen saturations, and if you fail to achieve oxygen saturation more than 90%, the patient after 4 hours, 6 hours, and still his oxygen saturation less than 92%, this is the indication for admission to hospitalization. Don't send him home because patient is still hypoxic. So never send asthma patient in the ER and he's hypoxic, never send him home. If you decide to send the patient home, he should have a normal oxygen saturation more than 92% in room air. CO2 is very important in severe and life-threatening asthma. You do blood gases, and usually in mild, moderate asthma, the patient is tachypneic, so wash out CO2. So CO2 is going to be low. While in patient with the moderate, with severe or life-threatening asthma, they start to have normal CO2, and even they have high or CO2 retentions because of hyperventilations. So CO2, if it's normal, this is a very serious indicator for severity of asthma and severe attack, and even if patients start to reaccumulate of CO2, this is also indicator severe bronchoconstrictions and life-threatening asthma. Inhaler or bronchodilators, usually inhaled salbutamol, short-acting beta agonist is always the first-line treatment for patient with asthma, and you have to give frequent doses, repeat doses every 15 to 30 minutes interval. So you give 1 sessions or doses, and you wait for 15 to 30 minutes, do other sessions, and do other sessions like this 4 to 5 to 6 times. Or you can give continuous nebulizations, not repeated doses. You can give continuous nebulizations. It's also not wrong. So you can use this modality of therapy, and is usually a dose 5 to 10 milligram per sessions, continuous nebulization per hour. Continuous nebulizations can be used for 1 hour to assist, but it's usually commonly not used. So it's unusual to see a patient who is receiving continuous nebulizations. Most of the patients receiving repeated dose of the salbutamol, and this is more than enough for majority of the patients. However, which one better, the MDI inhaler or nebulizers? Actually, there is no difference between them. So you can use inhaler device. So you can give the patient salbutamol inhaler 6 to 12 puffs of MDI as a spacer, which is equivalent to 0.5 milligram salbutamol by nebulizer. So the patient, you can give your patient either inhaler MDI or you can give nebulizer. No difference from scientific point of view. So both are effective. However, some patients, they may ask for nebulizer because of the psychological, they believe that nebulizer is more effective. And even some physicians, they believe nebulizer is more effective, but actually they are the same, no difference. So you can give your patient inhaler alone, MDI, but 6 to 12 puffs of MDI, which is equivalent to 0.5 milligram of nebulizer salbutamol. Ipratropium bromide, you combine it in patient who has severe, moderate, and severe life-threatening asthma, anticholinergic. Ipratropium atropine is combination with nebulizer. But in moderate asthma, mild asthma exacerbation, salbutamol is more than enough. Ipratropium bromide, the patient is not responding to salbutamol, or if the patient has severe or life-threatening asthma, you add ipratropium bromide, and this shows that reduce hospitalizations and improve in lung functions. And this is IV magnesiums on those patients. This is a meta-analysis shows that IV magnesiums in all clinical trials, and IV magnesiums shows beneficials in severe and life-threatening asthma, not in moderate asthma. Severe life-threatening asthma, IV magnesium is standard therapy in patients with asthma. So the overall odds ratio in those patients is 0.4. In the positive side, you see, as you see the meta-analysis results, the point to estimate a 95% confidence interval shows an overall pooled effect of the IV magnesium is 0.4. So IV magnesiums in all clinical studies shows beneficials in patients with the severe life-threatening asthma. Usually single dose, 1.2 to 2 milligram IV infusion over 20 minutes. It's very safe and very effective. Routinely to give for any patient come to the ER with acute asthma exacerbation, to give routinely IV magnesium is not indicated, it's not recommended. So it's not for every patient, only for a patient who has severe or life-threatening asthma. So moderate, mild, moderate, usually don't give IV magnesiums. And its use should be limited to those with severe exacerbation and not responding to treatment after 1 hour. So usually give it after 1 hour. So they usually start with the salbutamol plus ipratropium bromide. Don't give magnesium for the first minute of patient presentations. Wait 1 hour or 2 hours, patient responding, then you add IV magnesium. Steroid is well known that with acute exacerbation of asthma, reduce relapse and decrease subsequent hospital admissions. And which route of steroid, usually oral or IV parenteral steroid, they are equivalent, no difference. We prefer to give oral in bulk of patients. The majority of patients who came with acute asthma attack in the ER, oral prednisone 40 to 60 milligram daily is more than enough, particularly the patient able to swallow it. There is no vomiting, no nausea, patient level of consciousness is okay, he's not comatose, you can give it or he can take orally, please give it orally. No need to give IV or IM injection of steroid. IM or IV injections, IV infusion of steroid, you give it only if a patient is comatose, not able to take orally, he's nauseated, vomited, or patient in the ICU and ventilator, you give IV. But overall, generally speaking, the bulk of patients, the most of patients with acute asthma exacerbation in the emergency room, please give it oral prednisone, 40 to 60 milligram daily is more than enough. And usually, if he decide to give it the patient in the ER, you have to give it for at least 7 days in the same dose, and there is no tapering dose. You don't have to, after 7 days, you have to stop tapering down the dose. So 60 milligram, 7 days for adults is more than enough for acute asthma flare-up. And it's basically inhaled corticosteroid in asthma exacerbations. So if you give a steroid, do you need to give inhaled steroid? Usually, yes, you have to give it. Even usually, if you don't give inhaled steroid in the first few days, patient in the hospital maybe is not need. However, after 20 days, after randomization, 20 days post-discharge, they found that comparing to placebo and inhaled corticosteroid, using inhaled corticosteroid from day one on an admission and continue for at least 3 weeks after discharge, decreased relapsing rate. So the patient will not come back after 1 week or 2 weeks to the ER with other flare-up. So please give inhaled steroid from day one, and upon discharge, please continue on inhaled corticosteroid on those patients. Aminophylline is in the past is used many times, and almost every patient, like 20, 30 years ago, aminophylline was part of standard therapy for patient acute asthma attack. However, nowadays, in acute asthma attack, the intravenous aminophylline will not change will not add any beneficial to bronchodilators. So if the patient receiving bronchodilators, anticholinergic, IV magnesiums, steroids, you don't need to add aminophylline because it's not going to add any additional bronchodilator compared to standard therapy. So usually, intravenous aminophylline discouraged nowadays on treatment of acute asthma exacerbations. Except if you are in periphery, small hospital, small clinic, you have no options. You don't have nebulizers, and there is many problems. And this is the only available treatment in your hand, and you have to give it, yes. But if you're working in the ER and you have all facilities, all medications, all type of inhalers, nebulizers, steroid, magnesiums, so please don't give aminophylline because it is weak bronchodilators. It's not going to add any additional beneficial effect for the patients, and has a lot of side effects, as you know, very serious side effects, arrhythmias, nausea, vomiting, convulsions, and liver toxicity, and many other side effects. So antibiotic in patients with acute asthma exacerbation, most of acute asthma exacerbations due to viral infection. So the routine use of antibiotic is not recommended. So please don't give empirical antibiotic for any patient present with acute asthma exacerbation in the emergency room, okay, unless there is evidence of the pneumonia. If the patient has consolidations, patient has evidence of the infections, yes. But acute exacerbation of asthma without evidence of bacterial pneumonia, antibiotic has no role. because the bulk of those patients, the triggering factor for them is viral infections, and antibiotic doesn't work for viral infections. So antibiotic is not used, is not routinely given for a patient with acute exacerbation of asthma in the emergency room, unless there is evidence of pneumonia or bronchitis or the evidence of bacterial infection, depend on your clinical assessment. So the initial management of acute asthma attack in the emergency rooms, as I told you, is 3 categories. You assess your patient, either moderate or severe or life-threatening. If the patient has a moderate, and you assess your patient and categorize it, and you decide this patient has a moderate acute asthma exacerbation or flare-up, and definition of moderate is patient complete symptoms, agitated, neurologically alert, not comatose, respiratory rate less than 30, heart rate less than 120, oxygen saturation normal, peak expiratory flow rate usually from 75 to 50% of the predicted. This is a moderate. So what is the recommendations for treating the patient with moderate acute asthma attack? Oxygen saturation, you have to keep it more than 90%. Salbutamol, phentoline, nebulizers, or MDI, you can give 6 to 10 puffs every 20 minutes for 1 hour. So three backup sessions. So 1 session, 20 minutes later, 1 session, and other 20 minutes, other sessions. And then you assess your patient and usually give it after every hours according to the clinical response. This is MDI, with the spacer, that's fine, no problem, equivalent to nebulizers. But if you decide to give nebulizers, fine, no problems, no difference between them. And if you, the dose usually 2.5 to 5 milligram nebulizer, again, every 20 minutes, then 20 minutes, then 20 minutes for an hour, and then every 2 hours according to the response. And you have, even with moderate asthma exacerbation, you have to give oral prednisone stat, usually 1 milligram per kg, and up to 50 to 6 or 60 milligram per day. So oral prednisone, short-acting beta agonists, either MDI or nebulizers, oxygenations, and that's more than enough. So if you see this, there is no need for IV magnesium. There is no need for anticholinergic, ipratropium bromide. So this is a moderate asthma attack. While in severe asthma, basically oxygenation is always there. Oxygen is part of standard management of acute asthma attacks. So always you have to maintain oxygen saturation more than 90%. Salbutamol, either MDI or nebulizers. Again, 2.5 milligram every 20 minutes, then 20 minutes, then 20 minutes for an hour, then every 1 hour according to response. And now in severe asthma, you add ipratropium bromide, and usually 0.5 milligram or 500 microgram nebulizers. Again, combined with salbutamol, 20 minutes every 1 hour, then after every 4 to 6 hours as needed. So now you combined SABA plus anticholinergic together in nebulizers. And oral prednisone, again, you give stat dose of oral prednisone, 1 milligram per kg up to 50 or 60 milligram. Or in this case, if the patient has severe asthma exacerbation and he's not able to take orally, he's vomiting, nauseated, he's drowsy, refused to take oral, you may give IV hydrocortisone or IV methylprednisone 12 milligram per day, or IV methylprednisone 80 milligram per day. And now in severe asthma attack, you add magnesium. This is now you need to give magnesiums 1 to 2 milligram IV over 20 minutes. So now the difference between moderate and severe attack of asthma management wise. In severe, the moderate is short acting alone plus oral prednisone plus oxygen. In severe, the same as moderate, plus you add anticholinergic and you add magnesium on severe. While in life-threatening asthma as we define it, patient comatose, CO2 retentions, tachycardia more than 120, using accessory muscles. Okay, he's near fatal asthma. Those patients need to do a chest X-ray, ABG, CBC, renal functions. Now we give IV steroid, not oral, because patients not able to take it orally. So IV steroid, magnesium IV, and continuous nebulizations every 10 to 15 minutes. Okay, with both salbutamol and ipratropium bromide. And please remember that always you have to keep saturation more than 92%. So never leave your patient or allow your patient to go desaturating with hypoxia. So now, you decide your patient is moderate, severe, or life-threatening, and you treat him, okay, for 1 hour, and then after that you want to reassess, okay, and you see the response to treatment. If a patient responds, what is the definition of patient responders? Okay, or adequate response. Adequate response, patient symptoms improving, patient become more comfortable. Okay, vital signs start to become stable, or at least heart rate decrease, going down. Oxygen saturation more than 90%. Peak expiratory flow rate after 4 hours still more than 60% predicted. Okay, and adequate response should be maintained for at least 4 hours. So keep your patient at least 4 hours, then assess, patient respond, repeated peak expiratory flow rate should be more than 60% predicted, saturation normal, and then patient, you call it as responder or adequate responders. Those patients after 4 hours, plus 2 hours already initial management, maybe 6 hours, you can send him home safely. And remember, the most important thing to decide to send your patient to the home is 2 things. Oxygen saturation, normal, should be normal, and peak expiratory flow should be more than 60% of predicted. Please, if the patient peak expiratory flow rate still low, less than 50% predicted, even patient symptom improving, even oxygen saturation is normal, please keep him in the hospitals. Okay, so B is always, you have to always do for any patient come to the emergency room, please do peak expiratory rate, and you have to compare with the initial reading with the subsequent reading, and you see the difference between the 2 readings, and this is an indicator for response to treatment. And if you decide to send your patient home, of course you have to make a plan for him. It's not to send him home and that's it. You have to make a plan. The patient, given his inhalers, bronchodilators, you have to prescribe for him combination steroid and or ICS, inhaled corticosteroid plus LABA, check his technique, encourage compliance, educate the patients about the adherence, okay, adequate rescue medications, give him written asthma self-management plan, talk with him, talk with his family, be sure that he has a family support, be sure that he has somebody who can help him at home, check him home, he's not living alone, he's not living far from the hospital. And always, if you send him home, please give him follow-up in pulmonary or family medicine clinic within 1 week. Okay, so any patient come to the ER with acute asthma exacerbations and you decide to send him home, please let him come to our clinic or family medicine clinic within 1 week. Okay, don't send him home without appointment, without follow-up appointment in the clinic. So if the patient, this is responder, and you decide to send him home and you finish. The other group of patients, which is not improving after 4 to 6 hours in the ER, not improving, still symptomatic, minimal improvement in respiratory symptoms after 4 hours. However, his vital sign is stable, saturation normal, but peak expiratory flow rate is low, 33 to 60% predicted. So this patient not responding or partial responder, it's called partial responders. So symptom-wise improving, vital is okay, saturation is okay, but still peak expiratory flow rate is less than 60% predicted. Those patients continue. This patient, you don't admit him, you don't send him home. They need more observation in the ER. After 4 to 6 hours, you may give him other 4 to 6 hours later on. Okay, so total maybe 12 hours in the ER, need more observations, and you continue bronchodilator therapy, beta agonists, of course, ipratropium bromide every 1 to 4 hours. What next after that? After that, you have to assess them after that, and you decide after 4 hours, 4 plus 4 plus 2, this is maybe 8 to 12 hours, and then decide after that if he's complete responder, okay, or admit to the hospital, okay. So observe closely for sign symptom fatigue and of exhaustions. Monitor saturation always. Electrolyte ECG, of course, peak expiratory flow rate is always important. Is always you have to do it. And if the patient follow adequate response, of patient has after 8 hours, 12 hours, patient adequate response, then you have to make a discharge plan as already mentioned initially. Okay. If no adequate response, then the patient needs to be admitted to the hospital for further management. So non-responder, if patient is still sick, still tachypneic, level of consciousness is not improving, still fatigue, still patient has severe acidosis, peak expiratory flow rate is than 33%, patient requiring high flow oxygen and still oxygen saturation not raising above 92%, this is not respond. This patient need to admitted or ICU consultations and continue bronchodilators and systematic steroid, IV steroid, of course, because they are very drowsy and decrease level of consciousness. So you give them an IV or IM steroid. So the patient need to go to at least either ICU, depending on your assessment, or possible admission to ward for monitoring ward. So HELOX is very important to use in patient with life-threatening asthma, patient with a severe asthma, patient not responding to the initial management, which is SABA, anticholinergic, IV magnesium, IV or oral steroid, and still tachypneic, still acidic, still comatose, patient may be bending intubations. You may try HELOX, and HELOX, of course, is helium plus oxygen, usually 70% to 30%. Okay, and basically the HELOX is decrease the airway resistance, so the oxygen can pass very easily and smoothly, deeply to the peripheral airways and going to correct hypoxia. And this is most of the time, if you use HELOX, is going to prevent the patient from intubation and going to mechanical ventilations. But sometimes fail. But if you have it, and I think is most of the hospital, big hospitals already have it, and you try it. If it's failed, you go to mechanical ventilations. And most of the patients usually with HELOX, they avoid going to ventilator. So, however, if you decide to, if a patient has pending respiratory failure, he's comatose, he's acidic, he's type 2 respiratory failure, his CO2 started raising, and the patient needs intubation, please don't delay intubations. Do it as soon as possible. The more delay intubations, the poor outcome. So we have to act quickly. And you decide the patient needs intubation, need ICU admission, need ventilator, please do it and send the patient to the emergency room. If the patient has decreased level of consciousness and near airway protections, so some patient has severe bronchospasm in the large airways and in the neck on trachea, so need air protection, so you intubate them. And usually you avoid unnecessary sedations like histamine release usually, and paralysis ought to be permissive hypercapnia and low respiratory reserve volume. So all these things you can avoid, okay, if you intubate the patient early. But you have to be selective. You decide which patient you are going to intubate, which patient you are not going to intubate, depending on your clinical assessment. But all of life-threatening asthma, not responding to initial standard treatment for acute asthma exacerbations, you try HELOX, still patient not responding, you intubate him, ventilate him, and send him to the emergency, to ICU. And now, criteria for admissions. Criteria for admission usually, any feature of life-threatening attack. So which patient for asthma need to admissions? Patient, life-threatening, of course, admission. Moderate, 4 hours to 6 hours, assess if recovering, home, and make a plan. The severe asthma, 4 hours to 6 hours, initial assessment, then partial responder, you keep them for another 4 hours, 6 hours, assessment after that. Complete recovery, send them home with the plan. Not recovering, you have to admit him. However, the patient from the first minute or first hour, patient life-threatening asthma, this clearly everybody agrees that the patient needs to be admitted. Patient has significant symptoms, very sick. He's severely hypoxia, okay. And previous, if patient has previous history of near fatal asthma or brittle asthma, with patient previous ICU admissions, okay, need to be admit him. And if there is a reason for also for admission, if we are concerned about compliance, home circumstances, social circumstances, patient has no support at home, negligent, you think that if you send him home, if he gets sick, he's not coming back to us. Patient pregnant, has severe asthma exacerbation, of course, you have to admit him. So it's always clinical judgment, but this is very common sense indication for admission with acute asthma, for patient with acute asthma in the ER. So ER initiating preventive interventions, identify high-risk population. So we have decided which high risk. Any patient with asthma, even mild, we already told you, they are liable to have acute exacerbations or acute asthma flare-up. Okay, but the patient, particular patient, pregnant, poor social support or home support, patient previous ICU admission, frequent ER visit, poorly controlled pre-presentations, problem asthma care or asthma treatment. Okay, and those patients, you have to make a clear plan in the ER, and even when the clinic, when they come after 1 week in the clinic, you have to identify them, and you have to make an action plan and a clear educational program for those patients. So, what interventions are feasible in the ER setting? Initiations at discharge from ER, controller initiation. So, if you send patient home please don't send him only in oral prednisone. Send him in inhaled corticosteroid plus LABA combination, serotype or Symbicort. So please give him inhalers to take home, not Phentoline, inhaled corticosteroid, which is commonly available here is either serotype or Symbicort or Lirfar. Okay, asthma education programs, and this is going to bridge, and also you have to bridge the gap between the ER and primary asthma team or physicians or asthma specialists. Okay, because all this communication, all the interactions, there is always cooperations and between the two departments, or at least from the ER physician with a pulmonologist or primary care physicians, and to make a clear plan for a patient with asthma. So please feel free to call pulmonologist or family medicine to not only for admission, for asthma admission. If a patient decides to send him home, please call pulmonologist or call his primary physicians. Please tell him that patient come to the ER, he has these problems. I need to make an arrangement to see him in the clinic next week. That what you suggest, what you plan, and what you will do for your patient. And this is going to facilitate a lot of things, and going to avoid a lot of problems for this patient, and maybe avoid the patient coming back to the ER with other attack. So again, initiations of ICS at discharge has shown that is not commonly. So only by 2004, only 50% of patients with asthma coming to the ER, the discharging on inhaled corticosteroids. So 50% of the patient came with acute asthma attack, managing the ER, sent home. They were not sent any inhaler. They send an oral prednisone, maybe oral antibiotic, or maybe Phentoline, and that's it. Okay, so it's still we are lagging behind. So still bulk of patients with asthma, if you discharge from the ER, they are not discharged in inhaled corticosteroid. Please, if you send patient from the ER or from your clinical acute exacerbation, acute flare-up, please give him inhaled corticosteroid, either inhaled alone or with the LABA combination treatment. Again, this is a rate of the asthma death, or ratio of asthma death to MDI inhaled corticosteroid per year. So the less use of inhaled corticosteroid, the more death, the more use patients. So if you compare a patient they are discharged on inhaled corticosteroid, comparing with patient who discharged with no inhaled corticosteroid, they found out that patient discharged on inhaled corticosteroid, they have less death comparing with the patient discharged. And clearly the data shows that if you don't send patient home with inhaled corticosteroid, he's going to come back again to you, and there is very high risk of death, either at home before arrive to the hospital, or in the ER or ICU admission. So from my presentations, take home message, basically mild asthma are not spared from severe, even fatal acute asthma attack. So remember, severe asthma attack or fatal attack or acute asthma exacerbation or flare-up asthma, or what is called in the past status asthmaticus, it can happen or can occur at any type of asthma severity, even mild, moderate, severe asthma patient, controlled and uncontrolled. Okay, and the risk factor for flare-up or severe asthma exacerbations, basically lower use of controllers. Bulk of those patients, if you see them, they are not inhaled corticosteroid. If they are inhaled corticosteroid, the bulk of them, they don't need to come to the ER. They are compliant, adherence to the inhalers. Over-reliance on the SABA is very commonly. There's a lot of patients, they just using Phentoline, buy it from pharmacy outside, use it every day, and they eventually, later on, they end up in the ER because this is not treatment. This is basically is associated with high risk of exacerbation and death. And very important, if you see patient with asthma, severe asthma attack in the ER, interfere early assessment, manage early, do everything early. The outcome is going to be better. Even if you work in the crowded ER, many patients, but please don't neglect a severe asthma patient and don't keep him to last patient. Please deal him as, I don't see that deal him same as patient with myocardial acute MI or arrhythmias. I know this is life-threatening, but severe asthma attack is also life-threatening. So please deal with him as life-threatening conditions, which is the earlier you give medication or treatment or interventions, the better outcome, and avoid admission, avoid a lot of complications. And be aggressive with the bronchodilators. SABA, SAMA, IV magnesium, short-acting beta agonist, SAMA, which is anticholinergic, and IV magnesium is moderate and severe and life-threatening. Steroid therapy is very, very important. Oral or IV depend on severity of asthma. Other therapy like Helox is very important part of management of severe or life-threatening asthma. Evaluate, respond to therapy. Please, if you think the patient from the first minute to see him in the ER and you think he need to go to ICU, please call the ICU immediately. Okay, so earlier ICU referral very, very important. Earlier intubations, if a patient has life-threatening asthma, is very, very important. And you have to make an admission and discharge plan for those patients with moderate to severe asthma. So controllers, of course, discharge plan is control initiate, always controllers on discharge, education programs, and you have to communicate with the primary physicians, pulmonologists, or family medicine to make a future plan for the patients. And always the patient should be seen in the clinic after 1 week or 10 days of being seen in the emergency room. So the best treatment for acute asthma attack is a few days before its occurrence. The earlier, this is what's the message from here, the earlier interfere, the better outcome. So those patients, if they have action plan and they know how to deal, if they are patient educated and they have a good knowledge, education about asthma and how to deal with it, okay, and how to interfere, okay, and the patient, actually a lot of patients, they even avoid, they don't come to the ER, they take oral prednisone by themselves, they can nebulizer, they manage even by the family, some family, good family support, and they treat them even in their home, and they respond, and they don't need to come to the hospital, and even no doctor even know what's going on with this patient. So this is very important, that the best treatment for acute asthma attack is a few days before its occurrence. Thank you very much. I have to finish from this. I hope it was useful, practical, and basically this is, as I told you, this is Saudi or SINA, Saudi Initiative for Asthma Guidelines Group, published this month, like 2 weeks ago, in Annals of Thoracic Medicines, and basically it's consistent with international standards. So by now, any questions, or we move to the second talk? Tamer, can any questions, or moving to second talk?
Yes, Dr. Mohammed, please go for the second talk, please.
Okay, good.
We will take the questions after the second presentation.
Okay. I don't have it here, but fine. Okay. طيب. Okay. So my second talk is going to be about COPD, chronic obstructive pulmonary disease. COPD, basically, as you know, it's also one of the commonest respiratory disease because its main etiological factor for COPD is smoking, or a risk factor, basically, for COPD is smoking. And smoking, for example, in Saudi Arabia, around 30%, maybe 40% of population, they are smokers, so they're high risk of having COPD in the future. And the difference between COPD and asthma, COPD disease is elderly, so it starts to develop after the age of 40 or even 50, and usually progressive, slowly progressive disease. So it's not like asthma. Okay, so it's not disease of young and children. Okay, and I'm sure you know about the GOLD guidelines, Global Initiative for COPD management and treatment, and this is WHO also guidelines, and this is the most important, the most commonly used guidelines worldwide. And COPD is the fourth leading cause of death in the world. So the fourth is after cardiac stroke, I think trauma or accident, and then COPD. COPD number 4 nowadays as a cause of death. So this is a really indicator is really associated with very high mortality and morbidity. Death rate of COPD patients is very, very high. And in 2012, for example, around 3 million people died around the world. 3 million people died within 1 year because of COPD complications. And this represents around 6% of all death globally. So from all cause of death, 6% due to COPD. And it's going to be increased, okay, because of aging population increasing and risk factors, smoking increasing in the third world or at least underdeveloping countries, because smoking in our area is increasing, while smoking preference or incidence, actually, smoking incidence in the West is decreasing. So COPD probably is going to decrease incidence in the West, while in our region, smoking is very popular, very common. So COPD is going to be a big problem in the next 20 years. So what's the definition of COPD? COPD is basically very important to remember 3 important underlying words here. Common. Remember, COPD is common, even maybe you don't think about it, maybe you think you don't see it, but it's very common disease. And it's for example, in Saudi populations, COPD prevalence around 5% of the Saudi populations, or 4.5 actually, of Saudi population that have COPD. It's very common disease, while asthma is around 10 to 15%. I know asthma is more common, but 5% or 4.5% prevalence rate of COPD is common. It means it's common disease. Preventable, remember, very much preventable has intention to be written as a part of definition of COPD, because this is a disease which is, if you can interfere early, you can prevent it and prevent complication. So this is a disease which is, you leave it without interventions, without treatment, without stopping exposures, okay, the patient is going to end up have a lot of complications and respiratory failure and eventually death. So this is a disease which you can prevent it by simple education. Okay, and treatable, we have many treatable treatment options for patients with COPD, but as you know, not curable. So the patient, the moment they label to have COPD, is going to label COPD for the rest of his life. But you can control it, you can treat it, and you can decrease the burden of the disease, you can decrease the symptoms. And characterized by persistent respiratory symptoms, which is usually progressive shortness of breath and cough. So usually, shortness of breath is usually progressive over years and years. It's not a disease happening within 1 year or 1 month. Disease usually happens over decades, okay, and slowly progressive shortness of breath with airflow limitations. So you have airflow limitation, or means air obstruction, so obstructive airway disease, okay, not restrictive, so airflow limitations. And due to usually, that is due to airway and or alveolar abnormalities, and which caused usually by the exposures to outside irritants, okay, gases, environmental perfumes, biomass. This is important risk factor, but the most important risk factor, as you know, the bulk of COPD patients, actually 90% of COPD patients, usually smoker, or at least they smoke for 20 years, even before they quit. If they quit smoking, usually they smoke for several decades before they develop manifestation of COPD. So the symptom of COPD is non-specific because it can be present in any respiratory disease, dyspnea, cough, sputum production, mimic bronchitis, mimic asthma, mimic chronic lung disease, mimic pulmonary hypertension, mimic others, okay? And can be underreported by the patient. Some patients, they don't express their symptoms, so they are patient perceptions of the symptoms variable from patient to patient. The main risk factor for COPD is tobacco smoking. Tobacco, not only cigarette, all types of tobacco, okay, not e-cigarette, cigarette, water pipes, okay, smoking, all of them are risk factor for COPD. And then environmental factor, which is biomass, fuel exposures, air pollutions, it may have contributing factor for development of COPD. But the bulk of those patients, they are some sort of exposure to tobacco smoke. Okay. any patient above the age of 40, okay, who has a chronic dyspnea, progressive shortness of breath over years, has chronic cough, chronic sputum productions, he has history of exposure to a risk factor, particularly smoking, you have to think about COPD and you have to make a diagnosis of COPD. So any patient has respiratory symptoms and smoker and is above the age of 40, please, COPD is differential diagnosis. And how to make a diagnosis? You have to do spirometry. You cannot diagnose COPD without spirometry. You have all those patients with suspected, or we think about patient, he may have COPD, or you decide this patient may have COPD, you have to send him for a pulmonary function test to do spirometry, or you do portable spirometry is required to make diagnosis. Why? Because COPD is obstructive lung disease. Obstructive lung disease means you have to demonstrate obstruction of the airflow limitations by looking to the ratio between FEV1 over FVC, forced expiratory volume per second over forced vital capacity, and should be less than 70%. Normally, 70 to 80% above is normal. And those patients reduced because of obstructions, because air trapping, because dynamic hyperinflations. So the FEV1 patient not able to blow out air, so air retaining, so residual volume is high, forced vital capacity is higher, so the ratio should be less than 70%. So less than 70% is a must. If the ratio not less than 70%, this is not COPD. Okay, less than 70% FEV1 over FVC ratio. This is indicate the presence of the persistent airflow limitations. Okay, assessment. The goals of COPD assessment are to determine the level of the airflow limitation. So you have to decide what is the level of airflow limitation. So there is airflow limitations, less than 70%, but you have to decide severity or levels, could be mild, moderate, severe, impact of disease, which is quality of life, symptomatic symptom of disease, okay, and risk of future events. Risk of future events means assessment of risk of having exacerbations, admissions, death, okay, and then based on these three parameters, three factors, you have to decide what is the most appropriate therapy for this particular patients. So it's a personalized approach, personalized therapy. So what is good, okay, for that patient, maybe not good for that patient. So because you have to take three factors on assessment of patients, response therapy, level of airflow limitations, impact on disease, quality of life, symptom-wise, and the risk of the future exacerbations and hospital admissions. Okay. However, you have to remember that, for example, asthma, they don't have other comorbidities. So asthma is pure airway disease. Okay. While COPD, usually they have other comorbidities. So it's a multi-system disease. It's like a syndrome. So the patient with asthma, they have very high rate of cardiovascular disease, muscle weakness, osteoporosis, metabolic syndromes, diabetes, severe depression. 30% of them, they have depressions, anxiety, and they are at high risk of lung cancer. So all these other comorbidities usually associated with patient with the COPD. Okay, and this you have to investigate. You have to actively look very carefully to other comorbidities, treat if it's treatable, and all this will influence the mortality and hospitalizations independently. So to diagnose COPD, pathway, symptoms, risk factor. Symptoms, shortness of breath, cough, and sputums. Risk factors, commonly tobacco, but maybe other risk factors, indoor pollutions, occupations, biomass, etc. If the patient has these things, symptom plus risk factors, age above 40, please do spirometry. Okay, it requires diagnosis. So you see these three circles: symptomatic, risk factors, do spirometry, patient has COPD, yes or no, based on spirometry, which is the ratio of FEV1 over FVC ratio should be less than 70%. And this is spirometry. And the left side, on my left, I mean the right side of the slide, this is normal. Okay, normal spirometry, which is FEV1, for example, is here. The ratio FEV1 over FVC is 80%. This is normal. Okay, for example, FEV1 4 liter, FVC 5 liter, the ratio between them is 80%. While an obstructive lung disease, typically COPD, the ratio is going to be dropped. So the FEV1 is going to be reduced 1.8, for example. FEV1 3.2, and the ratio FEV1 over FVC ratio is here in this examples is 56%. So this is a moderate obstruction. So this is a typical graph of spirometric feature of obstructive lung disease indicating or suggestive of COPD. So COPD initial assessment, you do spirometry, you decide is it mild, moderate, and severe. First, post bronchodilators here. Post bronchodilators, FEV1 or FVC ratio less than 70%. Okay, we take it from there. Okay, then you do FEV1. FEV1. Gold 1, gold 2, gold 3, gold 4 depend on the FEV1 ratio. If FEV1 ratio normal more than 80%, this is gold 1, which is mild. It's very simple, non-specific COPD. Maybe a patient has no symptom at all. If the ratio from 50 to 79%, this is gold 2 or moderate COPD. If the ratio from 30 to 49, this means less than 50%, this is gold 3, which is severe COPD. And the ratio less than 30%, this is very severe COPD. If the patient has respiratory failure, of course, or on his own oxygen, this is advanced and palliative, basically, or severe COPD. And then you decide or assess this level of airflow limitations or obstructions. Then after that, you look for two things. You have categorized your patient either for category, either category A or B or C or D, depending on two things only, not on lung function here, depend on symptoms and number of observations. If patient has more symptoms, so for example, using MMRC score more than 2 or CAT score is a questionnaire, 10 questions. The score more than 10, there's more symptoms. Patient may have D, he's B or D. If he has less symptoms, less symptomatic, so the MMRC is 0 to 1 or CAT score less than 10 is usually A or C. Okay, and then you look for number of exacerbations, ER visit, admission in the last 12 months. If patient has one or none, he's either A or B. If he has 2 or more, he's either C or D. So A, B, C, D depend on two things: symptom assessment or quality of life assessment based on the questionnaires, and number of exacerbations in the last 12 months, 1 or less, 1 or 0, A, B, 2 and more, C and D. So prevention for COPD, of course, apart from pharmacological inhalers and medications, not all of pharmacological treatment. You have all of the patients with COPD should receive flu vaccine, influenza vaccine annually, pneumococcal vaccines every 4 years, and plus the BPC 13 once per life, and pulmonary rehabilitation if they have symptomatic poor quality of life, they have frequent symptoms, you send them to the pulmonary rehab program, okay? And we have it in Riyadh. I think they have 2 or 3 programs nowadays in Riyadh for rehab, okay? And the patient requiring oxygen, you send him, you put him in long-term oxygen therapy, and smoke cessation is important. Smoking cessation, counseling, smoking, long-term oxygen, pulmonary rehabilitation, vaccinations, and bioinfluenza vaccine and pneumococcal vaccine is mandatory on each patient with symptomatic patient with the COPD. Okay. What about long-term and invasive ventilations? The patient, you put your patient in a BiPAP at home. Long-term patient, usually not, most of the time, not, except in occasional patients who's a palliative, very advanced case, frequent exacerbations, many ER visits. For example, some patients, they come every month to the ER with frequent exacerbations, 1 or 2 ICU admissions. You may offer them a long-term and invasive ventilation. It's going to decrease mortality and prevent rehospitalizations. However, you have to be very selective and in your patient, you decide which patient is going to benefit from home BiPAP. Of course, you have a surgical intervention, bronchoscopic interventions by thoracic surgeons. Okay, this is maybe outside my scope of talk. It's very different talk, but is one option for advanced emphysema, either by lung volume reduction surgery or bronchoscopic intervention treatment. And palliative, those patients in terminal COPD, they are palliative, so we have to refer them to palliative care for palliative or symptomatic and supportive care. So management of stable COPD depends on assessment of symptoms and future exacerbation. So as I told you, symptoms plus exacerbation rate. Okay. And then treatment is not only pharmacological, but as I told, non-pharmacological by other means of treatment. And inhalers, pharmacological treatment for COPD, inhalers usually. Which inhaler that you choose your patient? It depends on many factors. What factors? There is no black and white decisions, depend on the patient preference, doctor preference, access, easy to use, cost and availability, and many other factors. Okay. However, if you decide to give your patient with this particular inhalers, you have to send him to educator, the pharmacist, even yourself as a physician, you may do it. Check the technique, be sure that the patient using the correct technique, correct way. Okay, otherwise, and it's not going to benefit from the inhaler prescribed for him. Bronchodilators, in bronchodilator for stable COPD, inhaled bronchodilator is preferred because symptom relief the symptoms. Inhaled bronchodilator is always relief symptoms. Okay, SABA is improved symptom and function. This is evidence A. Combination of the SABA and SAMA. So you give short-acting plus short of the SAMA superior to monotherapy or SABA alone or SAMA alone. Okay, so you need most of the time those patients with COPD they require combination inhalers. LABA and LAMA is evidence A is significantly improved lung function, dyspnea, health status, and reduced exacerbations. And this shows in many clinical trials that the combination of LABA and LAMA, and actually probably this is the best treatment for COPD, for symptom relief of patients with COPD is basically combine LABA and LAMA. LAMA alone, it may use in earlier COPD, like A or B category. Combination of LAMA and LAMA increase lung function, reduce symptoms. Combination LAMA and LAMA reduce exacerbation. So LAMA-LABA combination, LABA, which is a long-acting muscarinic antagonist, which is anticholinergic basically, with LABA, long-acting beta agonist, combine them together, not only reduce symptoms, but reduce exacerbations comparing to monotherapy. LAMA alone improve effectiveness of pulmonary rehabilitations. Thiophyllin has no role, please. Don't use thiophyllin because has weak bronchodilators, has a lot of side effects. Okay, so don't use thiophyllin in patients with COPD. Okay, so what's treatment you are going to use for your patients? Group A, Group B, Group C, Group D. As I told you, Group A, B, C, D decide based on two things. One is a symptom-based assessment and two questionnaires, MMRC or CAT, and based on exacerbations, 0 or 1 or more than 2 or more. Okay, if you put your patient in the Group A, which is less symptom, almost patient has very minimal symptoms, and he never had exacerbations, or maybe have one exacerbation in the last 12 months, bronchodilators usually short-acting SABA alone or LAMA alone may be more than enough for those patients. If the patient in Group B, at this stage you have to combine them, LABA plus LAMA, or combine them together, or you can give LABA alone, or combine them. Group C, LAMA, okay, or plus LABA or LAMA to combination therapy. Group D, usually you put LAMA or LABA, or ICS or triple therapy, LAMA, and inhaled corticosteroid for those patients. So, and management cycle, every time you see your patient, after a few months to see him again, review symptoms. Review symptom, two things, very important, symptom-based review, and two things. Assessment of dyspnea, okay, which is quality of life by using questionnaires, and exacerbations. How many times he came to the ER admission or ER visit. So exacerbations and dyspnea assessment. And then you have to every time assess, of course, technique, inhaler education, other non-pharmacological approaches, all of there, and adjust your treatment, escalate and de-escalate, depend on the patient assessment and based on symptoms and exacerbations. So, what about inhaled corticosteroid in a patient with asthma? With a patient with COPD, do you use it? For asthma, is standard. Is the first line treatment for asthma is inhaled corticosteroid. For COPD, not every patient with COPD need to be put inhaled corticosteroid. Actually, the bulk of patients with COPD, they don't need inhaled corticosteroid. You need a LABA or LAMA or combination with them. Inhaled corticosteroid used only in some small category of patients with COPD. What are these categories? Strongly support of using inhaled ICS treatment for patients with COPD. If patient has frequent exacerbations, multiple admissions, more than 2 moderate exacerbations per year, if the patient has uniphilia more than 300, or the patient has history of concomitant asthma, so asthma, COPD overlap. So the patient has some asthma component, or have eosinophil count more than 300, or has multiple admission, multiple ER visits, so a very sick patient, very advanced stage, ICS is usually part of management of patients with COPD. Usually not monotherapy, usually combined with the LABA or combined with LABA, LAMA, ICS, triple therapies. Nowadays it's become available. So in this diagram, review your patients in the clinic and you decide what is the predominant symptom, what is the predominant trait, we call it trait on this patient. Is it dyspnea predominant or exacerbation predominant? If the patient has dyspnea predominant but no exacerbations, so treatment pathway is different from patient who has exacerbation predominant, multiple frequent ER visits, multiple exacerbations, but he is not dyspneic in between or has mild symptom in between. So if he has dyspnea exacerbations and he's on LABA or LAMA, the next step you are going to combine them, LABA or LAMA. If he's still dyspneic symptomatic, then at that time you have to switch into an inhaler device or think about other cause of dyspnea. If the patient has predominant symptoms, dyspnea, and he's already on LABA plus ICS, and in this case you have to move him to LABA plus LAMA plus ICS. So we give him triple therapy instead of that double therapy, LABA plus ICS. You add LAMA as well. Okay, so LAMA, LABA, ICS. Okay, this is dyspnea predominant. If the patient predominantly exacerbations, so frequent exacerbations, but in between at home they have less dyspneic, they are comfortable, they have good quality of life, and the patient using LABA, LAMA, okay, LABA, LAMA, then and still have frequent exacerbations, you have to combine them, LABA, LAMA, or if the patient has some asthma components or has exacerbation more than 2, multiple admissions, or has high eosinophil count more than 300 in CBC, you have to add inhaled corticosteroid. If patient, okay, so LABA plus ICS, no LAMA in this case. So if the patient has still symptomatic, okay, with frequent exacerbations, then in this case you add LAMA for this patient. So LABA triple therapy, LABA, LAMA, LAMA. If the patient he's on triple therapy, LAMA plus LABA plus ICS, and still have frequent exacerbations, okay, multiple ER visits, but he doesn't have dyspnea, a lot of dyspnea in between, and he's in triple therapy, and in this case, okay, you may add macrolide, azithromycin. This indication of using macrolide in patient with COPD, if the dominant trait is exacerbations, and then in triple therapy, and still have exacerbations, macrolide 3 times per week for 6 months, okay, or roflumilast, okay, if there has mainly chronic bronchitis or the lung function is than 50%. Okay, so this is an indication of roflumilast or macrolide in patient with COPD in this particular trait. So again, review, assist, adjust medication depending on every time you see your patient, review them and assist your medication, assist your patients. Dyspnea, this is just repetition what already think. The main trait, the predominant trait, dyspnea, then follow again, same thing. For patient persistent breathlessness or exercise limitation on long-acting bronchodilator monotherapy, then in this case you have to add combination therapy. For example, if you have LABA plus LABA, you add LAMA. If LABA, LAMA, you add ICS, and switch. Or if they're still symptomatic dyspneic, then that time you have to check the device compliance, and maybe you think the patient has dyspnea due to other cause, for example, cardiac cause or other cause. Okay. This is again repeating what already mentions. If the patient has some evidence of asthma component or asthma overlap, or if you have patient some high eosinophilia, okay, and in this case, if the patient is in LABA ICS, you put them in LABA, LAMA, and triple therapy, LABA, LAMA, ICS. Exacerbations, again, if patient the predominant trait exacerbations, but they are not dyspneic, but they have frequent exacerbation, okay, acute exacerbation, then recover, then go back to baseline without significant home symptoms. Okay, if they are on LABA, LAMA, then you have to shift them to LABA, LAMA, and ICS. If they have some asthma component, you have to shift them. If they have eosinophil count more than 300, ICS is a must. Okay, if they have LAMA, LABA plus ICS together, okay, and still symptomatic, still have frequent exacerbation. In this case, you think about macrolide or roflumilast is mandatory. So macrolide, roflumilast, and in those patients is indicated on this particular trait on patient, predominant trait, patient with acute frequent exacerbation more than 2 per year. okay, they are less symptom or minimal symptoms in between the attack. They are in triple therapy. They are not responding. In this case, you may add azithromycin, macronide, or riflumast. And this is again the same thing what I already mentioned. I'm done with the management of COPD. I just review what I talk about definitions, how to make a diagnosis, okay, how to assess your patients, how to categorize your patient with COPD, either A, B, C, or D, and how to choose what is the best treatment for which category, and then how to review the symptom. Every time the patient comes to the clinic, you review two things: symptoms and exacerbations, and you have to decide which is the predominant problems or feature of this patient. Is it predominantly dyspnea with low exacerbation, less exacerbations, or mainly exacerbation, less dyspnea? And then after that, you decide what medications and here are going to give your patient accordingly. But remember, COPD is preventable, common, and treatable. And remember that COPD patient, their treatment is not only pharmacological, not only inhalers, not only LAMA, ICS, and other stuff, but actually you have to think about non-pharmacological treatment, which is vaccinations, rehabilitations. It's very palliative, non-palliative care, non-invasive treatment, and very important also you have to remember that, and long-term oxygen therapy and smoke cessation is very important. And remember, the earlier pick up your patient COPD in the early stage and stop smoking, you are going to prevent him to have long-term complications and suspected failure, coronary heart failure, and comorbid. And all of you have to think that patients with COPD, they have a lot of comorbidities, cardiovascular morbidities, depression, osteoporosis, diabetes, muscle weakness, fatigue, and many other things. There's a lot of those patients already is actually, they are bed bound and they are not able to move and are very thin or very weak, and they need a lot of help. I'm done with the COPD. I'm done with the asthma, acute asthma management in the ER. I hope it was useful. Now COPD, but this is an outpatient management, and I'm ready to answer any question for you. I'm sorry if it takes a long time, but I hope it was useful. Any questions?
السلام عليكم.
اهلا دكتور احمد.
حضرتك عامل ايه؟ Sorry for this noise, Dr. Muhammad Malish. Now for the questions, we have first question: what about OSA must be considered for every patient with asthma or COPD, because it is increasing the oxygen.
What do you mean? OSA means obstructive sleep apnea?
I don't know.
Or OSA means oral steroid?
Maybe oral steroids. Maybe oral steroid to be considered in the management of asthma or COPD.
Yeah, for both of these, for both of them. Usually for asthma, for COPD, for COPD, oral prednisone or IV is used only for acute exacerbations. I don't talk about acute management of COPD. It's different. This is different talk actually. I talk only in a stable COPD. But if you go to GOLD guidelines, and there is a chapter about acute COPD management of acute exacerbation COPD, and usually oral prednisone or IV prednisone used for 2 weeks. 14 days, 2 weeks. It's used for acute exacerbation. But long-term steroid for COPD has no role, generally speaking, and has a lot of potential complication, side effects, and very serious adverse effects. So please try to avoid it. For asthma, again, for acute exacerbations, 5 to 7 days has no rules in long term. Please don't put your patient in the long term oral prednisone. However, some patients, small category patients, severe asthma, frequent exacerbations, severely uncontrolled, you try them with many inhalers. They have been many years. They are in very bad shape. Okay, if you look at the guidelines, some patients you may see them in a small dose of oral prednisone as long term for 6 months, 1 year, like 5 milligram or 7.5 milligrams. Some patients 10 milligram, and actually some patients they just go and buy it and they take it for over the years, and they come to you with a lot of adverse effects, side effects, and they are obese, cushingoid, muscle weakness. Okay, so if you see asthma patient in long-term oral prednisone, please try to minimize it. Try to you have to find a solution for this, because nowadays we have a lot of biological treatment alternative. So
if I will see patient with asthma and on long-term steroids, I will send them to you.
Please, no problem. Okay. But nowadays, as one indication of biological therapy now indication for severe asthma, patient long-term oral prednisone, if you shift him to biological therapy like omalizumab or dopamine or many other biological therapy, you are going to get rid of oral prednisone. So try your best to get rid of oral prednisone in patient with long-term steroid in patient with asthma. But COPD is not part of its long-term management.
Okay, can we use fentanyl with Helix before sending them to mechanical ventilation?
You don't need to do this, because the idea of Helix means helium plus oxygen, 70%, 30%. Okay, so they are coming with one cylinder. How can we use the helium with fentanyl? It doesn't exist actually. Okay, but the idea Helix is just as a carrier for oxygen to overcome the airway resistance, so the oxygen can go very deeply to the peripheral airways and improve oxygenations. So helium per se is not treatment; it's just facilitate the passing of oxygen to the small airways.
Okay. Is dexamethasone more rapid in onset than hydrocortisone?
True, but usually most of these studies in asthma and even COPD is using oral prednisone or methylprednisone. Okay, but if you use it, it's not wrong, of course. All type of steroid, if you use it for asthma, is going to work. Okay, but if you go to standard guidelines, oral prednisone 1 milligram per kg once per day, stat dose in the ER, if patient take it orally, is going to work.
There is a question. He's saying that some physician in the emergencies, they just measure the CRB, then give antibiotic if it is high.
No, it's not. It's not. We don't. Is a clinical assessment. You have to go to the pneumonia scoring. If the patient had pneumonia, X-ray, there is consolidation clearly. Patient febrile, high WBC, sputum, greenish sputum. Okay, some evidence of upper airway infection, sore throat, and some start to cough and sputum. Okay, it depends on you deciding. But generally speaking, bulk of asthma patient in the ER, triggering factor, either something in environment, dust exposures, or exposed to very strong irritant at home or outside, or because of viral infection. Okay, so minus of patient, they actually have bacterial pneumonia, but it's you may see some patient with asthma, they have pneumonia and they need antibiotic, true. But not CRB, of course. We don't use CRB for this.
Okay. If a patient has oxygen saturation of 90%, do you prefer to use Venturi mask or normal mask? And what is the difference in use of Venturi mask versus normal mask?
No, it's if patient 90%. So with asthma in the ER, this is considered as severe. According to the guidelines, it's severe. And so desaturating asthma is severe to start with. So you have to give initially, if you can raise the oxygen saturation by nasal cannula alone, and saturation, we're looking for pulse oximetry monitoring. A patient already in a monitor, you see saturation raising above 92%, for example, 2 liters, 3 liters, or 4 liters, and saturation raising up, this is enough. But you may give more oxygen, depend on oxygen saturation. So your target is it's not the mode of delivery of oxygen and not how much oxygen you give. Your target is saturations. You reach saturation more than 92 or 94%, you are happy with 1 liter or 10 liters, depend on saturation.
There is another question asking you, what is your opinion about some practice they are giving the nebulization, the medication for nebulization through oxygen, not through the nebulizer?
Nebulizer, if you give nebulizer, you have to give oxygen with it.
Yes.
Okay. Fentanyl, I mean, short-acting beta agonist, bronchodilators, you give oxygen, don't give it alone. Okay.
Okay.
If you add anticholinergic, bromide, you have to give oxygen. It's all nebulizer with oxygen, nothing called nebulizer without oxygen. But sometimes some patients they have nebulizer at home, they don't have oxygen. Okay, if the patient in the ER needs a nebulizer, in the ER you have oxygen, you have to connect the patient to oxygen. But some patients, they buy the machine from outside and they take it at home and they are okay. It's not wrong, but we don't know what's their oxygen saturation. So always nebulizer with oxygen. Don't use it alone.
Okay. I'm sorry, Dr. Ruben. Everyone is taking the chance to ask you. We still have some questions. Please be with us. LAMA versus ICS. Do you prefer, which do you prefer in severe COPD, especially if there is overlap with asthma?
Yeah, as I told you, the indication, the strong indication of using ICS in a patient with COPD, if the patient has frequent exacerbations, frequent admission to the hospital, category D, or they have overlap asthma symptoms, asthma COPD overlap, or they have eosinophilia more than 300. Okay, so this indication for using ICS, but not as a monotherapy, not alone. Okay, usually as a with LABA plus ICS or LABA ICS, so triple therapy, LABA ICS, which nowadays is available in the hospital. Or if you don't have triple therapy, you add LABA together, okay, as one device. For example, this is Serotype or Symbicort, and you add LAMA alone, which is tiotropium, which is Spiriva. So these are triple therapy, but different devices. If you don't have the monotherapy as three in one device, triple therapy in one device. But so this indication for ICS. So it's not used for A or B or C, not used for mild COPD, not use ICS, not used for patients with have less symptoms or a good quality of life. There are some patients has mild cough, chronic, sometime in between. And if you do lung function, had mild obstructions, they never admitted, they never come to the ER. Those patients, if they are symptomatic like mild symptom, they benefit from LAMA or LABA alone as a monotherapy more than the ICS.
Last question. What about monoclonal antibody therapy to reduce attacks of asthma? And does monoclonal antibody has a role in COPD?
This is not for acute asthma attack, okay? For a chronic management of asthma is used nowadays biological therapy for long term, and nowadays it's become a very important management of severe asthma management. Okay, there's many biological monoclonal antibodies in the market nowadays. It's injection.
Okay, this is the last question.
Okay.
Thank you, Dr. Muhammad.
Okay.
We are very happy that you were with us today, and this will be the last presentation, and hope you join us next year, inshallah.
Inshallah. Thank you for the audience, and as-salama.
Shukran. And now, with the next presentation, second presentation for Dr. Rasha, our pulmonology consultant, we will talk today about pulmonary embolism. The presentation is a role of thrombolytic therapy in management of pulmonary embolism. على ايه؟ على ايه؟ مش قلت عشان الانشين؟ لا خلاص هعمل. ماشي اوكي اتفضل. اديها كرسيك يا ولد.
Good night. Inshallah, I will talk about thrombolytic therapy in acute pulmonary embolism. First, we have to know the mechanism of action of thrombolytic agent. It activates plasminogen to form plasmin, which accelerate lysis of the thromboemboli. Thrombolytic therapy is used in patients with acute pulmonary embolism to rapidly dissolve the embolic burden and improve cardiorespiratory hemodynamics. However, thrombolytic therapy is associated with bleeding, which can be catastrophic. So careful patient selection is critical to the success of this therapy. Because the adverse effects of bleeding can be devastating, only compromised patient in whom diagnosis of acute pulmonary embolism is highly suspected or confirmed, and in whom risk-benefit appears favorable should be considered for thrombolytic therapy. In most patients, the diagnosis is made by CT pulmonary angiography. However, ventilation, perfusion scanning, or pulmonary arteriography, which often immediately precede catheter-directed thrombolytic techniques, may also be confirmed. Occasionally, thrombolytic therapy is administered when diagnosis is made with bedside echocardiography in critical cases, which are shock that cannot be transferred to the CT pulmonary angiography. Thrombolytic therapy can be administered using empiric clinical diagnosis during cardiopulmonary resuscitation, but it is rarely successful in refractory pulseless electrical activity arrest. Because the decision to administer thrombolysis is difficult, a multidisciplinary approach that comprises a team of experts, including pulmonologists, cardiologists, thoracic surgeon, interventional radiologists, emergency department physicians, and pharmacists is needed. Many centers have created pulmonary embolism response team to facilitate rapid diagnosis and management of patients with pulmonary embolism who may be candidate for thrombolysis or other interventions. When making the decision regarding whether, when, and how to administer thrombolytic therapy, most experts consider early involvement of pulmonary embolism response team or other similar teams is critical. Factors that influence decision, we have to evaluate the risk of death from pulmonary embolism and the risk of bleeding from thrombolytic agent. We believe that it is important to place on the risk of bleeding relative to the strength of indication, which means risk of death from pulmonary embolism. The risk of bleeding from surgical trauma, for example, has greater weight if indication for systemic thrombolytic therapy is, for example, mild right ventricular hypokinesis with normal biomarkers, than if the indication is shock or cardiac arrest. As another example, while patient with pulmonary embolism induced shock who is unconscious, requiring very high doses of vasopressor, which is high-risk patient, is likely to benefit from immediate intravenous systemic thrombolytic therapy. The indication is not apparent. Sorry. Sorry for interruption. The other example, while patient with pulmonary embolism induced shock who is unconscious, requiring very high doses of vasopressor, is likely to benefit from immediate intravenous systemic thrombolytic therapy. The indication is not as apparent in patient who has low blood pressure for 20 minutes, but is awake, alert, and comfortable with low oxygen requirement. Despite a positive supporting data, pulmonary embolism response team help in these scenarios so that an informed decision can be made. There are high-risk factors in pulmonary embolism that predict poor prognosis we have to consider when evaluating for thrombolytic therapy. Persistent hypotension or shock despite adequate resuscitation, new or worsening right ventricular dysfunction, by any one or combination of the following: echocardiography showing enlarged right ventricle, increased right ventricle to left ventricular ratio equal or more than 1, bulging of the right ventricle septum into the left ventricle, reduce the right ventricle ejection fraction. Chest CT showing enlarged right ventricle, increased right ventricle to left ventricle ratio, contrast observed in the liver, also elevated biomarkers including troponin and pre-natriuretic peptide, and absence of comorbidities that affect right ventricle function. The third poor prognostic factor, simplified pulmonary embolism severity index more than 0, high clot burden, which means more than 70% perfusion deficit, proximal deep venous thrombosis in the lower extremities, significant hypoxemia and or respiratory distress, tachycardia more than 120 beats per minute, poor cardiopulmonary reserve, and presence of right-sided cardiac thrombus. Now we have to know about contraindication to fibrinolytic therapy in cases of pulmonary embolism. There's absolute contraindication, which is superior intracranial hemorrhage, non-structural cerebral vascular lesion, non-malignant intracranial neoplasm, ischemic stroke within 3 months, excluding stroke within 3 hours, suspected aortic dissection, active bleeding or bleeding diathesis, excluding menses, significant closed head trauma or facial trauma within 3 months. There are relative contraindications should be maybe considered: history of chronic severe poorly controlled hypertension, severe uncontrolled hypertension on presentation, history of ischemic stroke more than 3 months, traumatic or prolonged cardiopulmonary resuscitation or major surgery less than 3 weeks, recent internal bleeding within 2 to 4 weeks, non-compressible vascular puncture, recent invasive procedure, allergy from streptokinase, pregnancy, active peptic ulcer, pericarditis or pericardial fluid, and current use of anticoagulant like warfarin, which produce elevated INR ratio more than 1.7, age more than 75 years, and diabetic retinopathy. Once the decision is made to proceed with thrombolysis, the clinician needs to decide the optimal mode and timing of administration. While this evaluation is ongoing, patients should be anticoagulated, typically with intravenous unfractionated heparin. Some patients who experience deterioration from recurrent pulmonary embolism may already receiving low molecular weight or oral anticoagulant. The optimal anticoagulation is unknown in this population, but switching to unfractionated heparin is not unreasonable. Again, we have to know that there is absolute indication and relative indication for pulmonary embolism, for thrombolytic therapy in pulmonary embolism. There is a high, the first indication, which is absolute, is high-risk massive pulmonary embolism, which means presence of hypotension related to pulmonary embolism. Potential indication including patients with severe right ventricle dysfunction due to pulmonary embolism, which is intermediate risk pulmonary embolism. Others include presence of severe hypoxemia, particularly induced with contribution from concomitant cardiopulmonary disease. Patients with acute pulmonary embolism appear to be decompensated but are not yet hypotensive, and then extensive clot burden. The clinician should evaluate each individual for any one or more of the following factors that are thought to increase the risk of death from pulmonary embolism, other than refractory hypotension and shock due to pulmonary embolism with low bleeding risk. None of the listed factors by itself is an absolute indication for thrombolytic therapy. Now we have to know what is a simplified pulmonary embolism severity index. It is a simplified index which take into account several factors. Each one take 1 point. Age more than 80 years, take 1 point. History of cancer, take 1 point. Chronic cardiopulmonary disease, 1 point. Pulse equal or more than 110, 1 point. Systolic blood pressure less than 100, 1 point. Arterial oxygen saturation less than 90%, take 1 point. Low risk means 0, and high risk mean 1 or more than 1. When considering patients for thrombolysis, most expert clinicians use a combination of clinical variables and stratify patients according to the risk of death from pulmonary embolism as high risk, intermediate risk, and low risk. Sorry for interruption. 1 minute. أنا هنزل دلوقتي، اصبري عندي محاضرة 10 دقايق. I'm sorry for this interruption. Okay, خلاص. When considering patient for thrombolysis, most expert clinicians use a combination of clinical variables and stratify patient according to the risk of death from pulmonary embolism as high risk, intermediate risk, and low risk. In high risk patient, these patients considered hemodynamically unstable. However, it is needed to be known that significant heterogeneity exists among this group, ranging from marginal hypotension to refractory hypotension, shock, and cardiac arrest. Non-stress patients at high risk of death from pulmonary embolism are generally considered good candidates for thrombolytic therapy, assuming that bleeding risk is low. Intermediate risk. Within this category, a significant variation of the derived benefit from thrombolysis is likely. So selecting those most likely to benefit require additional assessment. Most experts consider intermediate risk pulmonary embolism as acute pulmonary embolism that associated with biochemical, echocardiographic, and or imaging evidence of right ventricular dilatation or hypokinesis without systemic hypotension. While not absolute, many patients in this category typically have a simplified pulmonary score index more than 0, while many patients in this category don't need thrombolysis. A selected group may be benefit. Some experts have subdivided this group into intermediate high risk and intermediate low risk categories. Patients in the intermediate low category are less likely to benefit from thrombolytic and should simply be anticoagulated in vast majority of cases, while patients in the intermediate high risk category should be considered for thrombolytic therapy. So we can divide the intermediate risk into intermediate low risk, which mean abnormal right ventricle function or elevated prenatrient peptide or troponin. In intermediate high risk pulmonary embolism, which mean abnormal right ventricular function and elevated pulmonary and elevated troponin or prenatrient peptide. Clinical features that should be taken into consideration during this assessment, including evidence of right ventricular dysfunction may present despite calculated simplified pulmonary embolism severity index of 0, and such patient may potentially benefit from thrombolysis if they meet other high-risk criteria. Certain older adult patients or those with underlying cardiac disease or on beta blocker may have inappropriately low heart rate response to the stress of pulmonary embolism. Some patients with acute pulmonary embolism may have an oxygen saturation of more than 90% at rest, but desaturate significantly with exertion or have postural hypotension. These features are not accounted for in the simplified pulmonary embolism severity index. While patients with extensive clot burden have been defined by some groups as moderate pulmonary embolism, this definition is not consistent in the medical literature, and not every patient with extensive clot burden has right ventricular dysfunction or need thrombolysis. Patients with simplified pulmonary embolism severity index more than 1 also meet definition of intermediate risk pulmonary embolism. Such patients must have abnormal right ventricle function and elevated prenatrient peptide or troponin before considering thrombolytic therapy. Finally, low-risk patient, they seem don't requiring thrombolytic therapy and should be treated with anticoagulant alone. The location of the thrombi, either peripheral or central, should be also assessed at the time, since the location may affect the method chosen for clot removal, like bulky central thrombi may require additional ablation locally, like ultrasonic or mechanical clot extraction. Again, we have to remind In short, about absolute contraindication to systemic thrombolytic intracranial neoplasm, recent which means less than 2 months intracranial or spinal surgery or trauma, history of hemorrhagic stroke, active bleeding or bleeding diaphysis like severe thrombocytopenia, non-hemorrhagic stroke within the previous 3 months. And relative contraindication including severe uncontrolled hypertension, non-hemorrhagic stroke more than 3 months, period surgery within the previous 10 days, and pregnancy. Thrombolytic therapy may cause moderate bleeding in menstruating women, but it has rarely been associated with major hemorrhage. Therefore, menstruation is not contraindication to thrombolytic therapy. Agents like aspirin or dual antiplatelet therapy increase the risk of bleeding, but in isolation are not contraindication to thrombolytic therapy. Caution is advised in patients who had pulmonary embolism inducing cope with resultant head trauma. Even if brain CT shown no hemorrhage in such cases, the risk of bleeding may be increased due to trauma that may undetected by head CT. Those in whom contraindication or high bleeding risk truly prohibit thrombolytic therapy, an inferior vena cava filter and catheter or surgical embolectomy are options provided the necessary resources and expertise are available. In most patients, thrombolytic therapy is administered immediately when there is clear indication like shock due to pulmonary embolism. However, in some cases, when the indication is uncertain, like intermediate risk pulmonary embolism, some experts observe the response to anticoagulant during the first 24 hours following the diagnosis. If during that time the patient improves, we will not proceed with thrombolytic therapy. In contrast, during that period, patients have persistent or worsening signs of distress like severe tachycardia, borderline blood pressure, poor oxygenation. We may proceed with thrombolytic therapy since the benefits likely outweigh the risk at that time. Once it is decided that thrombolytic therapy is indicated, so we have to discuss the method of administration, catheter-directed versus systemic, dosing for or reduced dose, and infusion versus bolus. Depending upon factors including hemodynamic instability, risk of bleeding, available expertise, oxygen requirement, and extent of the emboli, we will decide. In hemodynamically unstable patients, which are high-risk patients, and patient with low bleeding risk, the only widely accepted indication for full-dose systemic thrombolysis is acute pulmonary embolism, either first or recurrent event causing shock or persistent hypotension, which means systolic blood pressure less than 90, need for vasopressor or decrease in systolic blood pressure equal or more than 40 millimeter mercury from baseline for 15 minutes or longer despite resuscitation. Systemic thrombolytic therapy lead to early and rapid hemodynamic improvement. It will improve pulmonary arterial blood pressure, right ventricular function, and pulmonary perfusion. However, clear mortality benefit or reduction in pulmonary embolism recurrence not clearly proven. Most experts believe that benefit of rapid resolution of emboli causing shock or near shock is sufficient to justify thrombolytic therapy despite the increased risk of major catastrophic bleeding. In patients at moderate or high risk of bleeding who are unstable due to pulmonary embolism, guidelines suggest the catheter-directed therapies like ultrasound, saline rotational device suction with or without thrombolysis rather than full-dose systemic thrombolytic therapy. However, reduced dose systemic thrombolysis may be alternative if catheter-directed approaches are unavailable. While patients in this category may not ideal for any form of thrombolytic therapy, some experts administer catheter-directed thrombolytics when the benefit is believed to outweigh the risk. Catheter-based therapies are also an option for those in whom systemic thrombolysis failed, provided the necessary local expertise is available. A patient with hemodynamically unstable pulmonary embolism in whom thrombolysis is contraindicated, surgical or catheter-directed embolectomy are options. While American College of Chest Physicians support administration of catheter-directed therapy with or without thrombolysis as an option in hemodynamically unstable patient, in whom death is likely to occur before systemic thrombolysis can manifest effectiveness within hours. We believe that implementing systemic thrombolysis even delivered over 2 hours, in fact, nearly always faster than catheter-directed approach. Extracorporeal membrane oxygenation is a useful adjunct for supporting patients with refractory shock or hypoxemia from pulmonary embolism. The systemic infusion full dose thrombolytic in hemodynamically unstable patient, experts prefer systemic thrombolytic with typically tissue type plasminogen activator. This preference based upon the widespread availability and the clinical experience with this agent, as well as the rapidity with which it can be administered in life-threatening situation. Intravenous access need to be secure and central access not required. Necessary invasive procedures like intubation, intravenous access should be quickly performed while the infusion is being prepared, and all other invasive procedures delayed until after infusion is complete. It is preferred that the specialists in anesthesia perform intubation in these patients if possible, since sudden increase in the intrathoracic pressure from intubation and mechanical ventilation and hypotension from sedatives may have significant adverse effect of already compromised right ventricle and precipitate right ventricle shock. Dosing continuous infusion, we will give full dose IV thrombolytic infusion regimen, and this is the most common method. The most commonly used is recombinant tissue plasminogen activator. FDA approved alteplase 100 milligram administered over 2 hours. In more urgent situations like impending cardiac arrest, it is important to administer tissue plasminogen activator as bolus, as infusion over 15 minutes, or as 20 milligram IV bolus followed by infusion of 8 milligram over the next 2 hours. Bolus infusion of thrombolytic therapy is indicated for patients with pulmonary embolism-related cardiac arrest. During the infusion, the patient should be monitored closely for stability or improvement of vital signs and oxygenation, development of neurological signs, hemodynamic or obvious signs of bleeding. Clinical improvement is noted within the first hour of infusion. When infusion of thrombolytic agent is complete, IV unfractionated heparin is restarted. Considerable clinical judgment is needed when patients have bleeding while on thrombolytic therapy. Minor bleeding during thrombolytic therapy is common and not generally indication to stop therapy. Minor bleeding which occur at the site of invasive procedure like vein puncture or arterial puncture sites or in the skin and the gums, considered minor. And bleeding from vascular puncture site should be controlled with manual compression followed by pressure dressing. Many experts also tolerate bleeding from menstruation and bleeding that can be controlled at compressible sites. Minor bleeding from GIT or urinary tract may be managed by following clinically vital signs and hemoglobin. We have indication to immediately stop infusion and treat the bleeding, and these include hemodynamic compromise, persistent, mental status changes, significant reduction in hemoglobin by 1 to 2 grams per deciliter, need for transfusion of blood and copious amount of bleeding. If intracranial bleeding is suspected, clinical infusion of thrombolytic agent should be immediately discontinued. Following stabilization, a non-contrast enhanced CT of the brain and emergent neurological or neurosurgical consultation should be obtained. If the patient continues to have significant or refractory bleeding, despite cessation of thrombolytic agent, transfuse patient with 10 units of cryoprecipitate with or without 2 units of fresh frozen plasma and then reassess. Protamine sulfate should be considered to reverse the effect of any heparin that may remain in the patient plasma. When considering reversal, the relative severity of bleeding and thromboembolic process must be weighed in view of potential to exacerbate thrombosis. Following thrombolysis, patients should be fully anticoagulated with IV unfractionated heparin. avoid initiating longer-acting anticoagulant like low molecular weight heparin or oral anticoagulant or warfarin for at least 24 hours to ensure that there is no delayed bleeding that would require immediate cessation of anticoagulation. After thrombolytic infusion is complete, some experts start heparin infusion without bolus. To minimize the risk of bleeding, we check activated partial thromboplastin time and resume unfractionated heparin without loading dose when BTT is less than twice its upper limit of normal. If BTT exceeds this value, we repeat it every 4 hours until it is less than twice its upper limit of normal, at which time we can resume heparin infusion. Once stable for 24 to 48 hours, patient should be transitioned to oral anticoagulant like oral anticoagulant or warfarin. And the duration of long-term anticoagulation following thrombolysis is generally the same as for patients who not have received thrombolytics. We have to talk about the benefits of pulmonary of thrombolytic therapy on pulmonary hemodynamics. It will improve pulmonary artery pressure, right ventricle function, pulmonary perfusion more quickly than heparin alone, and the improvement generally occur over the first several days. However, it is uncertain whether these beneficial effects are persistent or not. Thrombolytic therapy has been shown in several meta-analyses of patients with acute pulmonary embolism to improve mortality at the expense of increased rates of bleeding. A meta-analysis of 16 trials reported reduced rates of recurrent thromboembolism with thrombolytic therapy compared to anticoagulant, 1.2 versus 3%. However, recurrent rates were assessed at varying time points, and the confidence interval were different, suggesting variability in this effect. Patients should be monitored or continued for signs of improvement like reduced heart rate and respiratory rate and improved oxygenation of blood pressure following infusion. Clinical improvement may continue for few hours and days beyond completion of the infusion. Although not routine, many experts also perform echocardiography 24 hours following the infusion to examine the size and the function of the right ventricle. While many cases demonstrate improved right ventricle size and function, right ventricle recovery may lag behind the clinical improvement. Now we will talk about catheter-directed approaches. Thrombolytic agents can be infused directly into the pulmonary artery via pulmonary artery catheter. Catheter-directed techniques has the potential advantage that lower doses of lactic agent can be administered, so reducing the risk of bleeding compared with systemic therapy. Clot removal can also be performed using catheter-directed approach, either mechanical, ultrasonic, or jet saline lysis. Both thrombolysis and clot removal can be performed in isolation or in combination. Typical access sites are internal jugular and femoral vein. Guidelines suggest that catheter-directed approaches are options for patients with persistent hemodynamic instability despite systemic thrombolysis, and those with hemodynamic instability due to pulmonary embolism who are at moderate to high risk of bleeding. Catheter-directed techniques should be reserved for use in centers with appropriate expertise since they are not without risk. The following are situations in which some experts typically contemplate thrombolysis in hemodynamic unstable patients with pulmonary embolism. The first one is intermediate high-risk pulmonary embolism, which is known previously as submassive pulmonary embolism, defined as right ventricle dysfunction together with elevated troponin or prenatriuretic peptide, particularly when there are other supportive findings like significant tachycardia, severe hypoxemia, respiratory distress, and extensive clot burden. A patient with acute pulmonary embolism who are clearly deteriorating but not yet hypotensive, which means showing signs of failing anticoagulation. Other patients are rarely considered for thrombolytic therapy in absence of right ventricular dysfunction. Although most patients described above may not need to be urgently treated with thrombolytic therapy, they should be rapidly anticoagulated. They should be also monitored closely since they are at risk of deterioration, and decision to administer thrombolytic therapy may need to be made promptly. In general, clinicians have time to discuss relevant options with patient and with other experts like interventional radiologists, pulmonary critical care, cardiology, or cardiothoracic and vascular surgery. Patients with intermediate high-risk patient may benefit from thrombolysis, and the rationale for thrombolysis in this population is based upon observation that severe right ventricle dysfunction is associated with a worse prognosis than mild or no right ventricle dysfunction. However, randomized trials have not shown convincing or consistent mortality benefit from thrombolytic therapy in patients with right ventricle dysfunction. For those in whom thrombolytic therapy is selected, it is suggested that catheter-directed techniques rather than systemic therapy, provided the expertise is available and the bleeding risk is low. Full-dose systemic thrombolytic therapy is a suitable alternative if local expertise is not available or the patient is not suitable or cannot transfer for catheter-directed techniques. While there are relatively few data, reduced dose systemic tissue plasminogen activator may also a reasonable option when catheter-directed techniques not available. Patients who don't improve or deteriorate despite anticoagulation may consider for thrombolysis as indication that supported by guidelines, and patients assessed to have high clot burden and or severe hypoxemia are sometimes considered for thrombolysis, particularly when these features are combined with other high risk factors for death from pulmonary embolism. The mode of administration of catheter-directed technique based on upon the same rationale as for those with intermediate high risk pulmonary embolism. In general, the rates of major bleeding range from 10 to 20% of systemic agent, while lower rates in the region of 4% or less have been reported for catheter-directed techniques. 2 to 5% may experience intracranial hemorrhage with systemic agent, while rates of less than 1% are reported in those who receive catheter-directed techniques. Thank you. I finished if thank you. I finished my lecture. If anyone want to ask, I'm ready. The first one, when you consider surgical embolectomy, when you consider surgical embolectomy needed, not thrombolysis. Yes, if the surgical embolectomy indicated if the patient meet the criteria for thrombolytic, like hypertension, severe hypertension, or shock or cardiac arrest, they can do pulmonary embolectomy, and they have absolute contraindication for thrombolytic therapy or intermediate high risk patient, but the bleeding risk is high. So if you have contraindication for thrombolysis, as I told before, we can proceed to surgical embolectomy. What about? Okay. What about NUCA? I cannot understand. I'm sorry, the second question, what's about NOCA treat like Xarelto for pulmonary embolism? I don't understand what's NOCA.
Okay, next one.
Okay. What about?
Okay, next question.
Yeah. No. asking for help. I didn't find questions. I think no questions. No questions. Thank you.
Thank you so much, Dr. Rasha. We will shift the last lecture for Dr. Khaled Hassan. It will be tomorrow. Thank you so much for your attendance today. Inshallah, we will meet together tomorrow at the same time, 4 p.m. Thank you so much. See you soon, inshallah. Assalamu alaikum.